Ghosh.
Yeah, sorry, I unmuted myself. Now let me share it.
Yep.
Yeah, there it is. You all can see it?
Not yet. We are seeing now. Yeah.
Yeah,
You
good. Yeah. Okay.
try to talk a little bit louder because we don't. You're a little bit low.
Is it okay now?
Now it's better. Yeah. Now
Thank
much
you.
better. Yep. Well, Professor Willingham, welcome. Are you ready? We're going to do test. Okay. Thank you. Thank you.
Does my sound good?
Yep. You sound great. A little bit. Could you try again?
Can you hear me now?
Yep. We are listening to you. Very nice view.
Yeah, nice background.
Of some kids. Professor Moriru.
Hello. Can you hear me?
Hello.
Can you hear me?
Yeah, we can hear you. We can hear, but we cannot see you.
Okay, how about now?
Okay. Oh, now better. Yeah, we can see you.
I cannot see
right.
even myself. What's happening?
All right. I just.
Oh yeah, I can see. Yeah.
All right.
Wonderful. Yep.
Your
So,
voice more
you,
Bruce,
yep.
is the voice more clear now?
Excuse me.
Can you hear me more? Yeah, can you hear me more clearly now?
Yes, but connection. It sounds good, but the connection is like a back and forth.
Okay.
Just try
Okay.
to, yeah, try not to move much. I think there are some situations with the earphone.
Okay.
Well, anyhow, I just I will give the welcome, and then after that, Professor Willingham will continue with this section, okay? So we have around 3 minutes more to go, and probably everybody is looking this test, but this is the technology we have right now, but we have to do the trial. Anyhow, feel free to try. You know the order already, and you already know the presentation. We are going to wait for some authority from the METHI to see if they can open this panel in this afternoon too. Just a minute.
Well, since we are seeing each other, I'd say hello to everyone.
Hello.
Hi, everyone.
Hello, Dr. Islam. Where are you from originally?
I'm originally from Omaha, Nebraska.
Ah, wow.
Yeah.
And now you're in Georgia.
I work in both places, so I travel back and forth.
Okay, so
Yeah.
are you at Case Western?
That's my original university. I graduated from there.
I see.
Yeah. Nice to see you. Long time, 3 years.
Yes.
Yeah. And hello to Dr. Ghosh and Prasad
Hi.
again.
Hi. So I suppose this is a panel discussion with 30 minutes of presentation.
Yes, I remember you said you would not be speaking initially for 30 minutes, but
Probably 25, because last night me and Crows kind of went over the slides. Most likely 25 minutes.
okay, good. Because I think we should try to keep to the time for everybody's presentation, because some people may come in late and looking to come in for particular speakers, I guess.
Right.
So we have like 20 minutes time for presentation.
Well, you can take the 30 minutes because we will save questions until the end.
I see. Okay. We can speed up or slow down. We can still make the time on. We'll be able to do that. That's what we're gonna do. Yeah. Give us a 5 minutes warning so that we know that we have to finish it up.
That's true.
Thank
How
you.
shall I do that?
Oh, you don't have any red card to show us? Or you can raise your hand so we know that time is up.
Okay.
Yeah. Because sometimes when we speak, we lost the time because we are in a mode of talking.
Sure.
Yeah.
So are you in Georgia now or in
No, I'm in Nebraska, Omaha now.
Okay.
I'll be going there in July 15. I do 10 days and 10 days back and forth. So I fly every other week.
Yes.
Now, because of the flying things, I don't know how I'm going to do it, but we'll see how it goes. Yeah.
Professor Carlos Rodriguez already inside. Could you try? Could you test? Dr. Rodriguez. Dr. Rodriguez.
Yes, I'm here. Good afternoon.
Okay. Vamos a oficialmente iniciar la actividad. Doctor Carlos Rodríguez, director de investigación del Ministerio de Educación Superior, Ciencia y Tecnología, en representación del ministerio y de su viceministro, el doctor Plácido Gómez Ramírez. De inmediato, el doctor Carlos Rodríguez. Adelante.
Muy buenas tardes. Saludos a todos en nombre de la ministra, la doctora Alejandrina Germán, y en nombre del viceministro, doctor Plácido Gómez, quien estoy representando en este momento, teniendo el honor de participar en esta sección con personalidades tan selectas como las de los paneles de esta tarde, en el de perspectivas epidemiológicas y abordaje de One Health. Mi imagen no se ve, no sé por qué, pero no creo que eso sea muy relevante. Pero me escuchan. Can you hear me? Okay. No sé qué pasa con mi cámara. Okay.
Ahora sí, se ve ahora. Adelante.
Entonces, el panel de esta tarde, situación actual de la pandemia COVID-19, y tendremos como moderador al doctor Aronia Willingham, alguien que ha colaborado bastante con República Dominicana y con los eventos que realizamos de los congresos que hacemos cada año de Ross University, y los panelistas Narayana Prasad de la Universidad de Harvard, Munro Islam, que también nos acompaña como usted siempre en este tipo de eventos, que es un colaborador muy cercano en nuestro país, la Universidad de Augusta, y Subik Gah de Ross University, también en Sakit. Entonces, luego de este panel, tendremos el panel sobre posibles soluciones terapéuticas y complicaciones mentales. El panel manejo de personas afectadas por la enfermedad COVID-19 y la pandemia. Son asuntos que hay obviamente que atender, que estará moderado por la doctora María Sonilda Núñez del Centro de Investigaciones Biomédicas y Clínicas del Hospital José María Cabral Ibáez en Santiago de los Caballeros, República Dominicana, y con la participación del doctor Carlos Rodríguez Tavera del Instituto de Microbiología y Parasitología de la UAS de República Dominicana, y Zoilo García de la Universidad Católica Madre y Maestra. Muchas gracias por aceptar esta invitación y por ser de nuestros panelistas. También quiero saludar a todos los que se integren a este a esta actividad de esta tarde. Todos bienvenidos y esperamos que podamos sacar el mejor provecho, que surjan muchas preguntas y obviamente van a salir más preguntas que respuestas de las que se pueden dar en línea, pero eso es importante que se hagan y también que se hagan comentarios, porque eso se puede integrar a una publicación que se va a hacer después. Entonces, luego de esta pequeña introducción, paso las palabras al doctor Modesto Cruz, quien modera toda esta sesión de hoy.
Muchas gracias, doctor Carlos Rodríguez, por sus palabras de apertura para este segundo panel del día de hoy. Y queremos dar algunas informaciones. La primera es que este será un panel sin traducción, un panel en inglés. De todas formas, este panel, como toda la semana, se está grabando y se puede localizar a través de las ubicaciones tanto del Ministerio de Educación Superior, Ciencia y Tecnología como la Universidad Autónoma de Santo Domingo y de la Facultad de Ciencias. En el YouTube pueden aparecer estas presentaciones que se van a quedar grabadas para ustedes. Las preguntas se pueden hacer, hay una sección especial de esta plataforma que tiene preguntas y respuestas. Entonces esperamos que todas las preguntas estén ubicadas en la sección de preguntas y respuestas, porque a veces cuando se escriben dentro del chat se pueden perder. Entonces eso es importante. Segundo, de inmediato vamos a dejar al doctor Albert Lee Willingham. El doctor Albert Lee Willingham es un gran colaborador nuestro, un veterinario, decano, o lo que se dice decano de investigaciones y de posgrado en la Universidad de St. Kitts. Un experto en citicercosis, al igual que un experto en One Health o salud única. En la actualidad acaba de ser presidente de la Asociación Centroamericana y del Caribe, es el presidente saliente de la Asociación Centroamericana y del Caribe de Parasitología y Medicina Tropical. Además, es un gran propulsor de lo que es la Fundación de Investigación en Salud Única, o sea, de One Health Research Foundation, a través de las colaboraciones con la Universidad de Rose. Lo dejamos a ustedes con él y sabemos que hará un trabajo excelente y todos ustedes podrán hacer sus preguntas en inglés y en español a cada uno de los panelistas. Estaremos presentes por aquí. Adelante, Dr. Willingham.
Thank you, Professor Cruz. It's always a pleasure to join with the conference in Dominican Republic. Regret that I'm not able to be there in person this year. We have a very exciting session this afternoon on epidemiological perspectives and One Health approach to the COVID-19. We have three speakers this afternoon. They will each be speaking for about 30 minutes, and then we will have questions after they give their presentations. So first, I would like to welcome Dr. Narayana Prasad from Harvard University, who is a specialist in cardiovascular medicine, and he's going to be speaking about the COVID-19 pandemic preparedness for crisis and the current situation that we're facing. So Dr. Prasad.
Thank you, Williamson. Can you hear me?
Yes, we can listen to you very well.
Oh, great. Thank you, Dr. Cruz. Thank you for the invitation, and it's a pleasure. I'm grateful to University of Santo Domingo and also Ministry of Health of Santo Domingo for giving us, me and my organization, an opportunity to share our knowledge, what we have gathered, and hopefully the next 20-30 minutes, I should be able to convey some kind of key messages to take home for all the audience that are listening to the conference. The presentation I've broken down, I'm going to provide some data, implications on cardiorespiratory effects, what is the current status from the public health perspective. We're going to focus some elements on an individual level. We will focus some on the institutional level. As you know, this is probably a public information. I want to share with you, despite the lot of discussion that's been going around, COVID is no longer a Chinese issue. Almost 50% of the COVID cases is happening on the western part of the world, and 50%, close to 50% of the death is happening on the western part of the world. You can see Santo Domingo is somewhere around 22,000 cases, with case fatality ratio is 2.6%. So this brings to some of the key things we in the health industry constantly measure. What is the country's capacity, which is number of hospital beds per 1,000 people. You can see the top 10, they are almost close to more than 10, and Santo Domingo stands at, Dominican Republic stands at 121st with a hospital bed capacity of 1.6 per 1,000 people. So here is a relatively 4 weeks old data. This is a Pan American Health Organization and world data coming out. So Dominican Republic had almost 3,000 hospital admissions with hospital bed capacity of 1.6. Almost 300 people were on the intensive care. So fast forward, this as of yesterday, this is the data we are looking at. This is from WHO, and 26,000 confirmed cases and close to 900 new cases. So breaking it down a little bit granular level, you can see there is some amount of variability in the both confirmed cases and also variation in the death that's happening over time. So on aggregate, this is from the New York Times, where the new cases are increasing. You can see the Dominican Republic is listed in that category. This was retrieved 3 to 4 days ago. On the other hand, there are some countries seems to be having some decline in the, especially in the Latin American countries and Caribbean countries, they're doing relatively a better job, or just the new cases are decreasing. So what is the problem with these charts? Number one, I heard some of the speakers this morning, uncertainty of the data. How accurately this data is collected, and how do we develop these models to generate these predictive algorithms to assess the future of the COVID. And lastly is the true case counts may not be unreliable because there's a huge difference in scale of testing. So this brings to why is it so hard for most of the healthcare professionals to look at. The symptoms is pretty generic. It is incubation period is 5 days. It can lead to multiple organ failure. Annals of Internal Medicine just published some of the symptoms that are pretty vague, starting from fever to the fatigue to headache to nausea. These are a very wide spectrum of symptoms humans can encounter for many reasons. Now, ESC, European Society of Cardiology, just published another one. They also spoke something on even a small speech droplets can potentially cause transmission of virus, just as normal speaking has some impact as long as you're in confined environment. So the whole challenge with COVID is its effect on the cardiovascular system. You know, you end up in ICU, they die from massive cardiovascular failure. So here is one of the publications that was came out early this year, which is from JAMA. It was actually published by one of my supervisors from our lab. Multiple pathways can affect myocardial infarction, heart failure, and cardiac arrhythmias. So this brings to next question, do we know COVID completely? There is acute phase that we are faced with. There is an intermediate phase, and there is chronic phase. If you look at the big picture of it, for healthcare professionals, the management depends on which stages we are trying to address. In the acute phase, we end up using different tools. In a chronic phase, we use different tools. Now, for those of the audience who are in medical school or in radiology or in cardiology, we know that right ventricle has always been there. Most of our focus has always been left ventricle. This came out just a couple of weeks ago. One of the key predictor for mortality of COVID is right ventricular enlargement. This was published in a JACC, Journal of American College of Cardiology, which clearly indicated there's a statistically significant difference showing normal versus dilated RV when you assess right ventricular pathologies during COVID. Now let's talk about the other diseases, which we tend not to focus on. This came out from our institution. This, you can see the 3 months data coming in January, February, March. During 2019, the distribution of disease care, cardiovascular care was pretty consistent. If you go into 2020, there is a dramatic, very spectacular drop in acute cardiovascular hospitalization. Something for clinical research group and healthcare providers to should look into what is going on with the other diseases. Is it just one institution? That's not the case. It's even in the entire state of Massachusetts is going through this similar phase. Even the admission of subjects from chest pain, heart failure, stroke, and other cardiovascular diseases have dramatically reduced over time by weeks, whereas COVID cases have increased in the state of Massachusetts. How about California, which is on the west coast of the United States, is a similar trend. If you look at this graph, it tells you 2019 acute MI was relatively higher than 2020, whereas COVID case took a very steep slope upwards. This was published in New England Journal of Medicine. Again, it came out of our team of cardiologists from Brigham and Women. In central part of the America, which is University of Mississippi Medical Center, similar trend. In 2019, there was a higher heart failure hospitalization. In 2020, there is a dramatic reduction in the hospitalization during COVID crisis. So what is going on with these diseases? Is it just that they are not being seen? Are we missing something larger than just carrying the acute crisis we are going through? So trend in outpatient care by the other diseases throughout the United States. This is another spectacular chart. They did a sample of 50,000 clinicians, 12 million visits. You could see in somewhere in the early March, there was a dramatic reduction. And as we move along towards May, you can see there is some significant, some improvement in outpatient care coming from other diseases. Now, we all know, at least in the United States, we talk about disparities within the vulnerable population. This came out June 18, where San Francisco noticed low-income Hispanic population have been major victims. Almost 96% of the new infections are in the Latin communities in the recent days compared to the early part of the COVID, where it used to be 67% Latin, 16% white, 17% other races, which kind of represents the normal population of the demographics. Now, what do we do with this? How do we prepare for a crisis like this? Going back to my original analogy, at the individual level, we can focus on personal protection, hand washing, social distance. On an institutional level, most important thing, every effort should be made for the capacity preservation. Let's look at the hand wash. I mean, you and me know very well, our hand goes to multiple locations throughout the day, whether you touching currency, the car, the credit card, gas station, you touch something else. Why is it so important? Because not all surfaces are created equal. You can see in this chart, which was published in a Journal of Hospital Inspection, that every surface has a different persistence of coronavirus. Obviously, plastic and paper can hold virus longer than steel and surgical gloves. So this is where our education should be driven as we move towards individual approach. So hand washing part, that's another area that where we tend to ignore. Most of us think washing hand is pretty common sense, but how often we wash our hand for 20 seconds? So this is from Georgia Department of Public Health. They kind of made a neat analogy where either you wash it for 20 seconds or you sing happy birthday twice. It's kind of a cool way of telling people, make sure you do it for 20 seconds. And a lot of publications, what happens if you wash it less than 20 seconds. Now, why is all this important with coronavirus? Most of the scientists in the audience know what R0 stands for. And R0 represents infectivity of the diseases. If a disease has R0 of 1, that means that person will spread the infection to one person. If disease has R0 of 3, that means that person can spread infection to 3 different people. This chart below indicates small change in the R0 has an exponential increase how cases can be spread over days. So that brings us to social distancing concept, which was, this is a neat chart, which is simplistic, but message is very powerful from Montana University, where if you have a normal behavior, you could infect 2.5 people. In 30 days, you will have 406 people infected. So as you reduce your exposure, so-called social distancing, what a dramatic decrease from 406 people to all the way to 2005, just by reducing your physical contact or any kind of contact and practicing social distancing. There is another data that came out in Washington Post, it was published. Just practicing social distancing has a huge impact. This color, infected people, represents no social distancing all the way to significant social distancing. There's a dramatic decrease in the infection rate passing through the population. Now, what is the risk of second waves? That's something this was published in Lancet early this year. So we all know that social distancing seems, or at least we are more confident that social distancing is working. What happens if you lift the social distancing? Once you drop the social distancing, you risk the second peak. Now, is this justifiable? Is this a predictive model? So this chart, which just came out yesterday from Johns Hopkins, clearly shows a first peak, and over time, it seems like it's going down. Slowly, it took us to the next peak. So question still comes, what do we do about this? And there's a lot of discussion going on. Should we just blame the government itself? Can government itself solve this problem? Is a question for all the policymakers and scientists and academic experts in the audience to try to come up with some kind of a collaborative process. Now, the next part is capacity preservation. We all know that healthcare system has a limited capacity. Now, if you exceed that capacity, you will overwhelm the system, not only by the current crisis, you will also take away the opportunity of caring of other people who are currently suffering from chronic diseases. This is a chart that was put out by CDC. Just using the protective measures uniformly, you may end up staying within the healthcare system capacity. And similar chart applies to the public health measures. And what implies with these two charts, both protective measures that happens at an individual level and public health measures that happens at institutional level has a significant value in keeping the healthcare system functioning optimal. Now, contact tracing, a lot of discussion is happening on contact tracing. Sounds easy, but can we really implement it? What are the challenges to implement the contact tracing? So currently USA needs 3,000 contact tracers. Fine. What if we do find contact and we discover 1 or 2 contact people? How are we going to support their food and medications and childcare and other costs if you planning on quarantining those questionable contacts? The next one, what about the cost efficiency of the testing? Going down, this is voluntary. So most likely, not everybody is willing to do this contact tracing optimally. So there is a fear of isolation and a fear of being penalized because you've been socially responsible citizens. So that's the burden of the contact tracing. Now, New England Journal published something recently, which is in June 17. We have so much data on phenotypes. Do we have enough data on genotypes of individuals? So this was published last week that says type A blood positive people more likely to have severe disorders, COVID compared to type O. That's a fascinating information where most of us are focusing on purely phenotypic distribution. This is the same publication. I just want to share with you some key points here. You get your first contact, you get approved by ethics committee, then you go to finish your genotyping. That's the process it takes. So that entire process has a window period, and it can vary from 2 different countries. Italians probably did a lot faster compared to Spanish genotyping. And that kind of correlates with, it takes time to start with the first contact, go all the way. That's 4 to 6 weeks. That's what the genotypic studies can imply here. So this is a very popular journal amongst all the speaker pools here, American Society of Microbiology. So they did a publication in April 2020. This came from Maryland group, Weston and Friedman, and they put a very powerful question to all of us. How do we control the intermediary host? How do we know the true count? And what is the lethality of it? What are the comorbidities and what comorbidities are associated with severe disease outcome? And how do these affect viral pathogenesis? Will there be a next coronavirus entering into human population? Because as we know, in the last 18 years, we have seen 3 major coronavirus outbreaks. That is not just a random coincidence. Now, those are the problems with pandemic we discussed. Now, looking at the individual level, what does it do to human psychology and the mental health? This came out in Brain and Behavioral Immunity publication at the early part of this year. They looked at some of the key responses amongst general population, first-line nurses, non-first-line nurses. If you look at it, there was a statistically significant variation just by pandemic having their emotional traumatization. Now, how do we deal with the treatments? As I just shared with you, that was from the pandemic. Now moving towards the treatment, where we are all in a lockdown effect, and when we lock communities down, you lose jobs, and loss of employment as a whole set of implications. This came from a Kaiser Foundation, a very reputable nonprofit organization in United States, doing a lot of great work globally. If you do not have shelter in place, 37% of the people felt negative impact. Now, if your shelter is in place, has a 10% difference, and they are considered statistically significant. Now, employment is also the same. If you did not lose a job, most likely it would have affected 40% of your mental health, but losing a job itself adds additional 14% of mental health negative impact. Thus, for the personal level, now I'm moving towards the institutional level, what are the implications as an intervention? Now, entire country, or most of the countries have interrupted their services. This was a sample, came out, 155 countries have been surveyed, WHO published this. More than 53% of the countries have disrupted services for hypertension, where hypertension is one of the critical comorbidity marker for COVID-19 severity. Additional 50%, no diabetes, no diabetic-related complication treatments. 42% of the countries have reported disruption in cancer treatment. And the list goes on. And in addition to that list, there is also second set of negative impact, which is reassigning the staff and postponing the screenings. 50% of the countries have postponed public screening programs for breast and cervical cancer. So that tells for all of us to understand COVID is not just a virus just trying to take us out in a short term. This is a massive, larger challenges. Now, the next challenge I would like to bring it to the audience is how are we going to deal with it as we move towards hurricane seasons? Communities are already affected. What about the voting during pandemic? I believe Dominican Republic is preparing for election, if I'm not mistaken. How well we can practice or adopt or execute democratic voting if the voting is going to be remote? Are we prepared for that? And how do we adjust for suicide and firearm injuries related to economical stress, social isolation, domestic violence? Last but not least is how are we going to address some of the implicit support system our communities had, either through the churches, temples, mosques? Those are all disrupted. So this slide I want to share with you as a group. We don't need to look at the government. We don't necessarily have to always blame other people. As you all know, in Europe and Madrid and Paris, it's a simple gesture. People stood out through the windows, started singing and cheering and appalling all the work healthcare were doing. That's a simple gesture. That's something we can do. And doctors and nurses are appreciated throughout by individual level. Now, institutional level, California just gave them one of the fascinating, most impressive good gesture. They gave them a voucher to 1,000 hotels so they can work and stay close to the sites, make their life much easier. So I do want to wrap up my discussion. I'm not sure how close I am to finish my slides. Strategic preparedness to the pandemic and lessons learned from the history is this. This yesterday, June 22nd, US not even is getting close to what Europe has done. Spectacular reduction on the European side. US has struggling to even to bring the curve down. The reason being power of messaging from the leaders, which means are we cohesively getting the message across? There's something called individual performance, which we talked about, social distancing, hand washing, and supporting the healthcare workers. And there's an institutional level where are we offering a lot of resources. So I just want to wrap up my slides giving these recommendations. History has already told us power of messaging is what drives everything. We have seen it everywhere, and a lot of big countries, big leaders have used very powerful messaging to influence the society. And we as collectively should look into that. So my recommendation here, based on my research, everything we do moving forward should be science and evidence-based. There must be public and private institutional partnership. Community engagement, very critical if you want to get somewhere. Integrated approach coming from life science, biotechnology, medical science, veterinary science, social division. You got to include everyone in the whole system and making sure essential services still functions. Strengthening the information exchange. Try to use the data, artificial intelligence and big data to predict and mitigate. I mean, this is what we do. This is what everybody is doing. So we should use these kind of resources to develop our homegrown models to help the communities. Last one, vaccine development research. I just heard on the news that Anthony Fauci just made a comment that with a cautiously, there's a chance we may have a hope of having a vaccine by the end of this year. With that, I want to end this. Despite this crisis, I do believe there is a great opportunity. Thank you for your time. I will be looking forward to all your questions.
Thank you, Dr. Prasad. We'll take those questions after all the speakers have finished. Let's proceed with Dr. Munro Islam. He's based at Augusta University in the great state of Georgia, where I originally come from. And he's going to be giving us an update on molecular epidemiological aspects of COVID-19. Thank you, Dr. Islam.
Well, thank you so much. But a little update that I am focusing on epidemiology of COVID, not the genetic epidemiology. Um, let's share the slide first. Are we seeing the slide? All right. Thank you so much, Dr. Wilhelm, for your kind introduction. And thank you, Dr. Cruz, for inviting me. And also to the management system, Dr. Placido, and the Ministry of Higher Education and Technology of Dominican Republic. This is a great opportunity given the COVID-19 global pandemic. We did not have the physical contact. So this online with conference is giving us opportunity to express our views, our research, and the way move forward. In fact, Dr. Prasad given already some of the data that I wanted to share. He already shared some of the data. But in any way, repeating is always good so that we can keep the key messaging continuously to the public and individual, and at the same time to the government who has the key responsibility to tackle with this global pandemic. So one of the things that I'll be doing, I'll be trying to give a very simple information in terms of the global status, at the same time what individual can do and what the government can do. And Dr. Prasad mentioned that the government has a very key role, especially the coherent messaging, which we are lacking in the United States. I could not wait to say this one, but I had to let it go, that this is happening in the United States. And he showed a nice slide about the how Europe is coming down. Contrary, we are rather than coming down and then going up. And then yesterday I heard from the government that they wanted to testing slowing down. But in any way, I'm not going to go into the politics. Let's focus on the presentation. Um, so as we all know, it started last year um, uh, from the, oh, sorry, some reason I am seeing the picture ahead of my slide. Can we move the picture? Like all of panels are in front of the slide. No, we can do nothing. Anyway. So last year, the novel coronavirus was identified as the cause of a cluster of 54 pneumonia cases in Wuhan, a city in Hubei province in China. And the disease rapidly progressed throughout the China, followed by increasing number in other countries of the global. In fact, in February 2020, WHO designated COVID-19, which stands for the coronavirus disease 2019. So this is the global status as of yesterday. By the global and at the same time WHO regions, 6 regions of WHO. And as you can see, the Americas are at the top, over 4 million cases, both in incidence cases and also in terms of the mortality. In Americas, over 219,000 deaths, followed by Europe and then Southeast Asia and so on. So this is one of the slides that I like very much. So this slide shows the number of confirmed cases on average daily diagnosed. And here, this slide shows some of the highest reporting cases in the globe. And as you can see, Brazil, US, and unfortunately, India is picking up. So there are some other countries that are showing nicely going down. For example, most of the European countries. The reason is obvious. They have done a good job in terms of the coordinated activities, both individual level and also at the at the government level. Next one is the confirmed new cases daily confirmed new cases, deaths by country, highest reported deaths by country. As you can see, the United States, after controlling disease in the New York area, we have started going down the mortality. But I'm not sure how long we're going to last this way, given the number of cases that we have started, increasing up in the U.S. Contrary, Brazil and India is picking up. Most of the European countries is going down, which is good news in general. The other one of the information that we are not showing a lot of information from other Southeast Asian countries and African countries because of their both reported cases and mortality is still pretty low compared to both Europe and Americas. Where Dominican Republic stands. As of yesterday, from the reported by the República Dominica Dirección General Epidemiología, about over 27,000 confirmed cases diagnosed and over 600 confirmed deaths. Now, this really don't give a good perspective if you want to compare where this, because this is a number of cases. We really cannot compare with Dominican Republic or any other country because of it is number. The denominator number, which is population, is different. And also not only the population, but also the health system, population demographic is different. There are comorbid conditions. There are many factors that are associated with incidence and mortality. But the one I like the slide, this one is the case fatality rate. In epidemiology, we use this very frequently for any infectious disease, especially diseases has mortality, quick mortality. It gives us a good comparison of the disease severity between a different population. So if you could see here, the Dominican Republic, as of yesterday, the case fatality rate was 2.44. Compared to many other countries, most of the countries are below 5%, except only 4 or 5 countries that are ranging from 10 to 15%. So the reason is there are multiple factors that are associated with mortality and severity of the disease. In terms of the Dominican Republic, has advantage in terms of the disease controlling prevention. It's an island country. If you close use one border with Haiti and not let any plane and ship land in your country, then you are pretty isolated country. So I think the government has done a very good job in terms of the early lockdown the country and doing a lot of activities in terms of the identifying, isolating, and contact tracing, which basically helps the country to contain the disease at the earliest stage. So let's move on to the some of the basic, very basic fundamental of epidemiology of COVID-19. So disease is here. We know that. So now how disease is transmitted from one person to another. At the beginning, even now, we did not have a complete understanding in terms of the transmission risk. In earlier studies from Wuhan, it shows that it was originated from a seafood market. But eventually we learned that the disease is capable from person to person transmit. And that's why we have seen this global pandemic, because of this capability of the virus to transmit from one person to another. Now, how this transmission happens, there are many factors that are responsible. One of the factor that we call basic reproductive rate, which you have seen from Dr. Prasad presentation. It is a very highly infectious disease. Initially, WHO reported its range below 2. R0 or basic reproductive rate was 2.5 maximum. But then all the recent study shows it can go up to 6.5 or 7 basic grade, which means the individual diagnosed with a coronavirus can infect up to 6 or 7%, which is not as high as measles, but it is much higher, at least 3 times higher than regular flu that we know, which is around 2 or 2.5 R0 or basic reproductive rate. So very highly infectious disease. This is a very highly infectious disease. It has the capability. The reason we are giving this very wide range of these lot of basic information because of a new disease. We did not know a lot of epidemiology. For example, yesterday it reported, I saw that on CNN that a paper published, I have not able to see that paper yet, that the about 80% of cases in southern part of USA are asymptomatic, which puts us in a very, very high alert rate that there are many cases that we haven't reported. So the number we are seeing are very likely it is underreported. So what we know about the transmission right now, that disease directly transmit from one person to another, close contact within 6 feet or 2 meters is another, and there are many these recommendations that we do the social distancing 2 meter is based on a study that published by Lancet, and they have did a good systematic review about 162 or 72 retrospective study. Based on that data, this recommendation was done. Now the critic will come and they'll say these are based on retrospective data, these 2 feet or 6 feet or 2 meter distancing. But all the evidence that we have based on data, the social distancing is working. And Dr. Prasad also showed you some of the data that social distancing can really substantially reduce the number of cases. The disease also has capable to transmit through the respiratory droplet. When someone speaks, cough, or sneeze, that can droplet information which can float in the air for some time. And if someone breathes, that can transmit the disease. Also, there have some information that can be spread. Study shows the data spread through the asymptomatic cases. Those who are asymptomatic cases, they are capable to transmit the diseases. As I mentioned earlier, if it is fact that 80% of cases are asymptomatic as much as, then we are in a big trouble because of the controlling, because it's very difficult to socially isolate or identifying asymptomatic cases is logistically almost impossible in a bigger population. There are some information that environmental contaminations can also transmit the disease. The surface area that we use, and as you can see, we can, as individual, we touch so many objects every day, starting from doorknobs to elevators, button, everything that are capable to transmit the disease. So in terms of the risk of transmission, the risk of transmission from one individual COVID infected varies by the type and duration of exposure. So depending on preventive measure that we take, whether we're maintaining the social distance or we are using the mask or any other factors these are all responsible, all factor in how this individual is transmitting to somebody the disease. Most of the secondary transmission happens within the household contact or in the congregates or in the healthcare settings where patients comes and the clinical personnel take care of them. But also there are some close, environment that can put someone at higher risk to transmit the disease. For example, cruise ship and airplane is another example. And also there are some report that cluster of cases after social or war gathering also heighten the risk of transmission through close but non-household contact way. So the disease transmit in multiple ways that I described, but now who is at risk? In fact, all of us, we all are at a high risk getting the infection, but some of us at higher risk for developing the disease and also suffering from the consequences of the diseases. Evidence suggests that age, race, gender, some of the medical conditions, comorbid conditions like hypertension, diabetes, overweight, lung diseases, chronic lung diseases put individual at higher risk to suffer from negative consequences of the disease. Certain medications, definitely living in poverty and crowded place are a risk for higher risk for someone to contact the disease and also suffering from deadly consequences of the disease. Certain occupation puts someone as a higher risk, healthcare workers at higher risk also unless they are taking proper precautions for prevention of the diseases. And also the pregnancy is also a risk factor for the higher pregnancy, higher risk, women are at higher risk for developing the disease. So knowing risk factor help us to identify the healthcare needs for the individuals. So that's why it is important that we identify individual risk and assess their health status for the proper healthcare needs assessment. So now we know that disease is here, we are here. And we know there is no treatment, targeted treatment, and also no vaccine yet. Hopefully, there are several vaccines in the pipeline. Hopefully, all the news and everything we hear that we will be having early next year. That's the earliest time, but there are some updated news every day that we are very hopeful and positive that there will be a vaccine soon. But what we can do as individual level and also as the institute or government level. Individual, we can do frequent hand washing, and it is recommended that we wash at least 20 seconds each time. Soap is a good way to get rid of this because it kills, basically disrupt the cell wall of the virus, and it's a very good rather than using any other chemicals. Avoid close contact, maintain social distancing, and it usually cover individual mouth or face and nose. Now, this is one of the things that we need to discuss about this. The using regular face mask is not protecting individual from getting the disease. Rather, it is helping not to spread the disease if you individual are sick or having the disease. Personal, maintaining cleaning and disinfectant and monitor health status so that we can control, predict and identify disease early enough for intervention. Now, government level, there are many things can be done. At this current situation requires certain strict reinforcement. Some of the European countries and Asian countries are doing it very nicely. India, Bangladesh, and Pakistan, these are good examples of maintaining lockdown situation well, given the crowded environment, economically, disadvantaged people, but they are doing very good compared to, I would say, in the United States, because we have here we call the individualistic idea. We don't care about the about the society as a whole. We always think about myself, and it's my freedom. I'm gonna use it or not use it. It's none of your business. That's what I heard from a lot of people, which is unfortunate, but that's a fact right now. So let's government can also reinforce the social distancing. They can ban, as Dominican Republic government did. So they can international travel restriction, and also a lot of activities, social gathering that can be making legally, reinforcement so that the individual cannot do that. In fact, Dominican Republic had up to June 5th, I believe, they had the curfew, and also they had done a lot of good thing in terms of the blocking the roads so that internally people can travel from one region to another region. So government has done very good job in terms of the containing the disease. Now, before I go to my next two slides, I wanted to show some of the myth and fact about the COVID-19. So there are some information out into the internet, which is internet is blessing to us. That's why we know a lot of things about COVID, but it also has spreading a lot of negative information. As you can see on the left-hand side of the slide, you don't have to read on the right side. Those are the facts. But if you're tired, you can read those. You can see that what weather can kill the virus that causes COVID-19, which is really not true. If you take hot bath and hand dry can prevent COVID-19, that's not fact. Also, there is saying that COVID-19 transmit through mosquito bite, which is again myth. Thermal scanner can detect COVID-19. In fact, not. It can detect the temperature, fever, if someone has the COVID, but fever can be many other reasons. There are some information out there that vaccination against flu and pneumonia can prevent COVID-19. Taking several other over-the-counter medications, vitamin C, there are many other things. Even it was in CNN, you have heard that hydroxychloroquine, our president was taking it. So, these are all myth, not scientific-based, evidence-based information. Older people and children are vulnerable. In fact, older people are vulnerable to the severity of the disease if they get the diseases because of their comorbid conditions. Wearing mask, as I described earlier, it cannot prevent you getting the disease, but it can help not spreading the disease if you are the disease. An antibody cannot is not a therapy because it is a virus. So developed country has a lot more greater resources, expertise to handle the COVID situation compared to low and middle income countries. Dominican Republic is a middle income country, and as you can see, is heavily burdened by COVID, lack of awareness, compliance, financial status, infrastructure, human resources, and expertise. The reason I showed this myth versus fact, because given different countries, social structure, economy, remoteness, and living isolated in rural areas, there are a lot of myth and other things can impact the society. So the important message for the Dominican Republic government would be scientific-based prevention measures. That would be the ideal, so that they can use social distancing and also other activities that I mentioned earlier. One of the important information would be the campaign and raise awareness, and also deprive myth and induce compliances. So all the myth and things that if there is something in rural and isolated area, it should be disapproved and try to increase awareness that these are myth, not fact. and also recognize the prevention and overall management of such health crises more difficult in low and middle income countries. So we have to recognize that the resource limitations. And also have a global threat preparedness in terms of the plan for the health crisis, response for health planning during the crisis, and also have the plan at the end of the crisis, how to solve the disruption of the society, disruption of the economy, given once the healthcare crisis is over. So government should have some kind of plan in place right now. And also cooperation of healthcare providers and administrative bodies, and especially government and non-government organization and at the national and global level. One of the important issues that the Dominican Republic should focus involve local healthcare professionals, especially community clinics and clinical staffs. I have seen working with many developing countries in Africa and Southeast Asia that the individuals, whenever they get sick, they rely on their local pharmacist heavily. They trust them, they go to them, they talk to them. So it would be really prudent to involve these local healthcare providers, especially into the national program in terms of the COVID prevention purposes. And also, finally, the government should continue resource allocations, which is very important for long-term effectiveness, prevention and management purposes. So government is doing a good job, but they have to continue to support these activities. This is my last slide. I don't have any other slides, so let's share with the, if you have any questions or anything else.
Thank you, Dr. Islam. We'll save the questions until after the final speaker.
I wanted to show, this is my 20 months old mini Labrador. So the reason I showed you Modesto, Dr. Cruz, he knows, but I wanted to show everyone, this is my beloved dog and he is very sick right now.
Oh. Thanks again. Thank you for those epidemiological aspects of the situation. So now we're going to hear from a virologist who happens to be a veterinary virologist and hear about the One Health approach to the situation. So we have Dr. Ghosh as our final speaker.
Thank you, Professor Willingham, for the kind introduction. I would like to thank Dr. Cruz and the organizers for the kind invitation, and I would like to extend my congratulations to the previous speakers for the excellent talks. So I would like to share the screen. Can you see it? Can you see the full screen? This is something I keep on telling my students when I teach them over WebEx, and I keep on repeating. So excellent. So we heard great talks about COVID-19 and being a veterinarian and being a virologist. Needless to say that COVID-19 has fascinated me a lot. And I am going to speak on COVID-19 from a different perspective. I'm going to speak from the One Health perspective, which is a very important perspective, because if it was followed diligently, then all of these could have been avoided. So I will not elaborate on this slide because I believe that my previous speakers, Dr. Prasad, Dr. Islam, has done a great job introducing COVID-19. It's an RNA virus. It has been also baptized as SARS-CoV-2. And there is a strong belief that the virus has a zoonotic origin and it has been possibly derived from bats. This virus has changed a lot of things, right? As humans, we believed in something very firm, that united we stand, divided we fall. oh my God, and now we have a virus that has changed that very basic concept of mankind. Now it is divided we stand, united we fall, thanks to social distancing, which of course is helping. The funny thing is, had we reinforced the concept of One Health, which is based on the foundation of united we stand, divided we fall, we could have combated pandemics such as COVID-19. And this is the aspect I'm going to speak upon today. So before I go ahead with the application of One Health to COVID-19, this is the definition of One Health as outlined by the One Health Commission. Put very simply, it takes into account multiple collaborative efforts between different stakeholders, ranging from medical doctors, veterinarians, environmental scientists, all the way to sociologists, anthropologists, mathematicians, and so on, to combat, prevent, and contain diseases and ensure healthy animals, healthy environment, and of course, healthy humans. And this is how the One Health umbrella looks like. And why is One Health important? As you can see here, the numbers will speak, I need not. 60% of the existing human diseases are zoonotic. At least 75% of the emerging infectious diseases of humans have an animal origin. And it is a happy, sad feeling to say that most of these are viruses. And 5% of the new diseases that appear every year, almost 3 of those 5 have been traced to animals. So it's high time we need an One Health approach to combat pandemics like COVID-19. So I have different sections for this presentation, and the first one is tracing the origin of zoonotic coronaviruses. Zoonotic viruses are like a complex puzzle. You know, they have the multiple pieces, they have the multiple characters. And if one of these misses, you don't come up with the origin. You don't know from where the virus has been derived from. And this is where the concept of One Health comes in. These are some of the zoonotic coronaviruses that have been detected in humans, and I shall not elaborate on this slide because of time constraint, but all of us are familiar with the last 3, the SARS-CoV that appeared around 2002, 2003, MERS that was in 2012, and then of course now we have SARS-CoV-2 that is COVID-19. And all these viruses were zoonotic. But what was interesting, when SARS was first reported, nobody was sure whether it is a zoonotic virus or not, right? It was reported in 2002, 2003, around 800 people died. It spread across the parts of the globe. Then in 2005, they started looking into animals, and the results they obtained were fascinating. They found viruses that were closely related to the human SARS virus in bats. And then eventually they found SARS-like viruses in civets. And based on extensive genomic analysis of viruses that were reported in bats and civets, these hypotheses have been proposed. 1, the SARS virus may have emerged from genetic recombination events in bat, and it got transmitted to civet because the SARS case was reported in Guangdong, where the bats were from Yunnan, 1,500 kilometers apart. Of course, we don't know the migratory path of bats, whether they travel that long, but it is known that there is a wild animal trade in China, and animals are being transported from Yunnan to Guangdong. So based on this, they came with the hypothesis that the SARS virus underwent a series of mutation and recombination in bats. Then it got transmitted to civet, where it underwent further mutation. These civets were brought to the animal market, and all of you have seen photographs of the wet markets, how they are, how the animals are caged, they're in close proximity. Immunosuppression, environmental condition further attributed to accumulation of more mutations. There have been multiple transmission of the virus to human, and then there was that ill-fated transmission that resulted in the emergence of the SARS virus. But wait, a recent study had more fascinating findings. They detected antibodies to SARS virus in humans living next to the bat caves. So we have 2 hypotheses now. 1, bats, civets, human. 2, directly from bats to human. Going further, again, the same story. In 2012, we have the MERS outbreak in Middle East. And then, of course, we had cases in another outbreak in Korea. And there has been sporadic cases in other parts of the world, right? Now, the story of MERS is very interesting. Although MERS was detected in 2012, retrospective studies revealed that MERS virus was present in camels long time back. And based again on high throughput sequence analysis, they found that MERS virus may have been introduced into camels from bats almost 30 years ago. And therefore, bats are the progenitor, the bat viruses are the progenitor of the MERS virus that we see in humans, which may have got transmitted from camel. And the recent MERS-related viruses that have been reported do not have the affinity for the same receptor as the MERS virus for humans. However, again, recent studies have revealed MERS-like virus in bats that bind to the same receptor as that of MERS virus in human, that is the dipeptidyl peptidase receptor. So all this is possible because of a One Health approach where you look into animals. But until MERS, it was all retrospective. First, the disease is detected in a human, and then you start looking into animals to find the solution. Now comes the big one, the SARS-CoV-2 or the COVID-19, and it is popularly known as. Now, this time, we were more well prepared. Exhaustive collaboration between the EcoHealth Alliance in New York and the Wuhan Institute, which is in the limelight, they had sequenced large number of bat coronaviruses from China. So when this COVID-19 virus was reported, they found that this virus shows a 96% match with one of the bat virus strain collected in 2013. But although it was a 96% match, these bat virus had key differences in the receptor binding domain, and it lacked a cleavage insertion site, which are very crucial features as far as infectivity of COVID-19 goes. They also detected another bat virus by whole genome sequencing again, which had the cleavage insertion site. However, genetically it was divergent significantly from the COVID-19 virus. And then we have these pangolins, which are of course sold in wet markets. Now this pangolin has a coronavirus genome that is different from COVID-19. But what is interesting is the RBD or the receptor binding domain sequence of this pangolin coronavirus is very highly related to COVID-19. So based on this, there are several hypotheses that are going on. They say that it may be a direct transmission from bat to human thanks to multiple recombination and mutation event. They say that it may have been transmitted from bats to pangolins, recombination event, maybe some other intermediate host, and got transmitted to human. And there is even another hypothesis that says that the virus got introduced into human from animals, and it got introduced before December. So it has been circulating. And of course, there is evidence now. They found the virus in sewage water in Italy in December. They found the virus in France before December, and they had indication of the virus in China way before December. So they say that it may be a cryptic spread, where the virus is silently mutating and spreading in humans. You don't see any severe clinical sign, and then the mutations happen, and you start seeing cases, severe cases of COVID-19. Now, this shows that how important is One Health, because if we don't have surveillance, genomic analysis of viruses circulating in animals, especially wildlife, we don't know from where these viruses emerge in humans because they're novel viruses. Now, COVID-19 may be a new virus to us. Human coronaviruses are rare. Means occasionally there has been instances where the viruses have crossed the species barrier and infected humans. But for us veterinarians, we are quite familiar with coronaviruses for a long time. And let me tell you something. Coronaviruses are enigmatic. They are mysterious. You don't know how coronaviruses are going to behave. And as Dr. Prasad shared some very good details about, the clinical presentation of COVID-19, although primarily considered as a respiratory disease, but there has been instances of this virus being associated with extra respiratory signs, right? different organs have been involved, including Kawasaki-like disease in newborns. And of course, I'll use the word associated because it is not yet established. It may be an immunopathology reaction, or there is a recent publication that says the viruses have been reported in organs. But what I would like to say here is I would like to share some examples of coronaviruses in animals that are very mysterious, that are very enigmatic, and that are COVID-19-like. And one of the best examples is coronavirus in dogs. Long time back, coronavirus was known to cause mild enteritis in dogs. In 2006, a new variant emerged that caused systemic disease. Multiple organs were damaged and the animals died just like that. It's called pantropic coronavirus, against which even vaccines are not effective. Of course, we don't have any successful vaccine against canine coronavirus. There were some deletions, you know, in this pantropic coronavirus, and virologists said that, well, this is the cause, but no. Later on, they found pantropic coronaviruses that didn't have the deletion, yet they caused a systemic infection. So apparently there is some genetic change going on in that virus that entirely changed the pathology of the virus, the tropism of the virus. Furthermore, this is in a good sense, transmissible gastroenteritis virus causes severe diarrhea in piglets, high mortality. And then you have a deletion mutation, a part of the gene is chopped off from this transmissible gastroenteritis virus. Wow, you end up with a respiratory porcine coronavirus, a virus which was infecting the gut causing diarrhea, one deletion, and it causes mild respiratory disease. The good news is it offers protection against the more virulent transmissible gastroenteritis virus. But the hallmark of all coronaviruses with which I draw a good analogy to COVID-19 is feline infectious peritonitis. Feline infectious peritonitis is caused by a coronavirus. And as you can see in this slide, 70% of the cats, they suffer mild diarrhea, they recover, they continue to shed the virus. It is quite widespread in the feline population. But then you have the 1 to 3% of the cat that develops a very severe form of the disease called feline infectious peritonitis. Now, what happens here? Now, when the feline coronavirus is present in the gut, it undergoes mutation, and that is hypothesis. Okay, it is not yet been established, but that is the most accepted hypothesis. Then there are few hotspot mutations, maybe in the spike protein encoding gene, that changes the nature of the virus. The virus infects the monocyte and macrophage, and once the virus infects the monocyte or the macrophage, there is a release of large volumes of cytokines, quite similar to the cytokine storm that you see in COVID-19 patients. And then there is formation of antibodies. Great news, there is formation of antibodies. However, these antibodies bind to the spike protein of the virus and helps the virus to further infect macrophages. More and more macrophages are infected, more inflammatory reaction, formation of immune complex, formation of pyogranulomatous lesions in the blood vessel, necrotizing vasculitis. These infected macrophages, they behave weird. You know, they release interleukins that can cause apoptosis of lymphocytes. So you see lymphopenia, and it skews the immune response from a Th1 to Th2 immune response, further facilitating humoral immune response, which is not good for this, right? So basically you see a few mutations transformed a harmless enteric virus to a deadly systemic virus, whose pathology is primarily immunopathology, quite similar to what we see in COVID-19. Now the next part, wow, we have so many COVID-19 vaccine candidates. Great news, it's very promising. By the way, veterinarians have been working on coronavirus vaccines for a long time. Do we know what's happening there? Let's see what's happening. First of all, studies have shown that coronavirus infection in animals may confer short duration immunity. Studies have been conducted in feline coronavirus, and they found that the duration of immunity may be a bit short. Now, until now, the only licensed vaccine that is available in animals is against infectious bronchitis virus. And this is a oral virus. You know, this is a oral vaccine. This is a parenteral vaccine. And this parenteral vaccine has been found to reduce severity, but it does not prevent infection. It does not prevent viral shedding. So if you have a vaccine that can reduce the severity, but it does not prevent infection and it does not prevent viral shedding. On the other hand, you know, there has been attempts to develop a vaccine against feline infectious peritonitis. There has been conflicting results about this vaccine with regards to its efficacy. And they recommend to administer the vaccine, you know, after 16 weeks, but cats are exposed actually before the 16 weeks of time, right? So the American Association of Feline Practitioners do not recommend this vaccine. But there is a problem with this feline infectious peritonitis vaccine, that is antibody-dependent enhancement. Antibodies induced by this vaccine can actually facilitate the infection of macrophages by the coronaviruses and can cause a severe response. Studies have shown that immunized cats suffer a more severe disease. Studies have shown that, you know, that immunized cats suffer a more severe disease compared to control cats. So as of now, as you can see that the vaccine status in case of animal coronaviruses is quite doubtful. Although we have some vaccines against the coronaviruses that cause gut infection, and they have been quite promising, but as of now, the only licensed vaccine against respiratory coronavirus is the infectious bronchitis virus in poultry, and it's a parenteral vaccine that can only reduce severity, but does not prevent infection and viral shedding. On the other hand, the feline infectious peritonitis virus vaccine has been discontinued because of doubtful results with regards to efficacy, onset and duration of immunity, and the problem of antibody-dependent enhancement. Now, studies on MERS virus has been done in hamsters, and antibody-dependent enhancement has been shown with the MERS virus vaccine in hamsters, but not in mice. So one of the potential side effects that we should be aware of with coronavirus vaccine is antibody-dependent enhancement. This is what is the concept of antibody-dependent enhancement, where the antibody facilitates the entry of the virus into the infected cell, further aggravating disease. Moreover, the antigen-antibody complex deposits in the blood vessel, causing severe vasculitis and edema. This is a case of feline infectious peritonitis, but as I said before, antibody-dependent enhancement has been also seen in hamsters during trials with the MERS vaccine. Now, the other aspect of One Health is the environment. And I feel that we humans are responsible for what is happening. You know, what you reap, you sow. And we open the Pandora's box, right? And I need not elaborate this, but this beautiful cartoon, it explains everything. You know, while we humans are scratching our head trying to figure out how this virus originated, we are speaking about environment, climate change. The environmental habitat has those answers for us. Deforestation, you know, constructing dams on river, climate change, illegal wildlife trade. These are all the factors, including human encroachment, you know, that have opened the Pandora's box, and we are facing the wrath of it, right? History repeats itself, right? We saw the SARS in 2002, 2003. We saw the MERS in 2012. Recently, there was an outbreak in pigs by a coronavirus from bat, and now it has come to attention because of COVID-19, and now you have COVID-19. We should learn. If we don't learn, we will become history. So one of the best things is to reduce host contact potential. If the pathogen doesn't come in contact with the host, we are safe. These pathogens are in their own habitat. They are not in cities. They are not in towns. So it is very important that we close the Pandora's box, we keep it closed. It's very important, you know, that we have to stop deforestation. We have to advocate to prevent climate change, because natural disasters, you know, they can destroy habitats, and the carriers of the viruses that live, that sustain in the habitat will enter human civilization or vice versa, and we'll have pandemics like these. Of course, another very important aspect is to ban animal wet market and illegal animal trade. The civets that tested positive for SARS virus were from the animal market. They did a metagenomic survey of viruses in the Wuhan market for COVID-19. They found positive samples, but they believe that those samples were environmental, maybe from humans that visited the market, because no animals based on published data were sampled. But nevertheless, it is very important to ban animal wet market and illegal animal trade. And then, you know, we can't stop humans. There will be deforestation, there will be encroachment in this habitat. So what to do? Monitor it. It is very important not only to perform exhaustive surveillance in humans, but we should also perform exhaustive surveillance in animals, especially wildlife. And we should also perform surveillance studies in humans staying next to this wildlife habitat. Remember that antibodies against SARS virus have been detected in humans staying next to bad habitats. So this is very important, and this gives you the chance to know what's happening. And we should not be restricted only to surveillance, because coronavirus is a plastic, the genome is plastic. It is not like a coronavirus from a bat directly jumps into human. It undergoes a series of evolution changes. So it is very important to monitor the gene pool, the plastic gene pool of coronaviruses in animals, especially wildlife and humans. For this will give us the warning signals that this virus is changing and there may be a chance of spillover. And then, of course, we should learn from animals, animal viruses. You know, there is a lot of interest in the immunity in bats. How can bats sustain coronaviruses yet they don't suffer severe disease? And there has been recent review articles, publications on that. This is something that we should learn. We should learn how the changes in the coronaviruses can influence tissue tropism in animals. They have answers for human coronaviruses. We should learn about the vaccines, the success and failure stories, the strategies that have been used in animals. And of course, we should use animal models to study viruses like COVID-19. So this is a summary of the recommendations, you know, based on this presentation. And these are all based on One Health concept. And if you read these, you will find out that this cannot be achieved by a single professional. It cannot be achieved by a single expert. It requires a concerted effort of multiple stakeholders, ranging from doctors, veterinarians, virologists, epidemiologists, molecular biologists, public health expert, mathematician, computer scientists, environmental scientists, zoologists, anthropologists, and so on. So united we stand, and we can successfully fight the virus. And my university, Ross University School of Veterinary Medicine, has always followed this One Health mandate. And we have established a 19,000 square feet research pathology complex with advanced BSL2 labs that are focusing on different diseases and also other topics like, you know, ecosystem and food safety and security from the One Health perspective. And we are not only restricted to One Health research, but we also offer a wide array of courses to create the next generation of One Health specialists. So with that, I complete my presentation, and I thank you all for your patience. And this is what is One Health. If we had diligently adopted the One Health concept, then we could have been sleeping, you know, in a relaxed manner under the One Health umbrella, which would have protected us against COVID-19. Thank you.
Thank you, Dr. Ghosh, for that very passionate talk on One Health approach to the pandemic and coronaviruses.
Thank you.
And thank you, speakers, for keeping to time. We're right on the mark at 5:30, so we have a half an hour for questions. I can see that there have been some submitted already, and let me just go through a few of those. There's a question about contact tracing and why it's considered to be difficult.
Okay. All right. Can you hear me?
Yes.
Okay. I guess that question is for me. You know, I think I had a slide to share. Conceptually, it's very common sense. You know, once you say that contact tracing, okay, I'm going to ask you, hey, who did you touch? Who did you talk to? I just go to that person. I'm going to get that person. It's easy. But one of the biggest challenges is to resource allocation, right? You know, you have to assign those people, train them. The second big challenge is once you get the contact, how are you going to address it if you as a policymaker, as a country, as a morally responsible healthcare provisions? I'm going to get someone, and I find two people, two mothers of 4 kids, and they're single moms or whatever you see. How do I isolate them? How do you know? Quarantine is a principle of contact tracing. They need to think of all the support system, child support, loss of income, loss of revenue. An enormous amount of resource allocation goes in. The second part is how do you trace them without infringing the freedom? I mean, obviously, if I choose not to speak who I touch, you cannot force me. So it's a multi-dimensional concept, and we went through this in what is it, Ebola, for example. You know, we went through this discussion in HIV in India. You know, we already talked about it. The social stigma and a fear of isolation will disrupt the whole cycle. Now, makes sense? Yes. So what it needs is a lot of education, wide contact tracing, resource allocation, and very good planning for contact tracing.
Can I add something on top of it?
Yes, go ahead.
Oh, thank you. As Dr. Prasad mentioned, that it is a very resource required endeavor. We have been doing this for example, STD controlling in a county level. But even few hundred STD cases, just to contact tracing, it's cost thousands of dollars. Now we are talking about not thousands, it's millions of cases. So it's virtually almost impossible when you have millions of cases doing their contact tracing. But what can be done in the way I think is a little bit abbreviated version or some kind of a modified version. One of the thing would be looking into at the bigger picture, like if it is for example, some of the developing countries where the resources are limited, what they are doing, if they identify cases in a small area, so what they do, a couple of blocks, they confine that blocks in terms of they call the local lockdown or some modified version. And then they use 2 weeks a time. No one can come in and come go, and they contain the disease. This is a modified version of containment of the disease, rather going individual contact tracing, because we know there are many people in a very, especially in developing countries, where there are a lot of people living with the small area or locations. So many people will be in contact with one cases even a day. So that's why it is important that we use a lot of innovative idea. Contact tracing is a very successful method for controlling other infectious diseases, like we had Ebola, HIV, and also common STDs, gonorrhea and chlamydia, and also syphilis. But with COVID, it would be all very challenging, as Dr. Prasad mentions.
I just want to add just 1 or 2 sentences. Most of us live in United States are aware Boston was one of the major hub of outbreak. And there was a biotech conference in Boston, right? All the healthcare professionals had a major, without going to the specifics. And that's where a huge cluster of cases came out. And they all walked in Boston on the campuses of, they walked on the State Street, Harvard campus, Cambridge campus, and all the contacts that went with it. So it is challenging. So that's my answer, but it requires multi-dimensional planning. That's the only thing I'm saying. Next, anything for me?
Thank you. A couple of questions for Dr. Prasad. You mentioned about people of different blood groups being at perhaps greater risk. If you could explain a bit more about that and the reason perhaps this is occurring. And also there's a question about, it says DVT. I assume that means deep vein thrombosis, and whether that is predisposing people with COVID to more cardiac related problems related to COVID because of deep vein thrombosis.
Right. Okay. So let me go to the first one, which is primarily how do you vaccine part, right? Not your genetic blood. Let me just talk about the genetic component. Historically, most of the infectious diseases, correct me if I'm wrong, I have a lot of experts on the board, phenotyping is a lot more easier. Ethical committees, approvals, getting someone's genetic testing is a feat, especially if you live in a lot of scrutiny and IRB processes. Based on the New England publication that came out just a couple of days ago, there's definitely, they picked up 2,000 people who were COVID positive, approximately another 2,000 people, and they developed the 8 million genomic analysis. That's a lot of work they did. And it takes time. That's one of the slides I showed you, getting the process. And they discovered type A seems to have a severe form of disease. Nobody, even from a professor, I forgot the name at this time, NYU and Columbia said, we cannot possibly explain why group A are more risky for getting COVID versus sitting as non-genetic experts. I'm not a genetic expert. I may not be able to break it down to the granular level, but genetic genetic assessment, genotyping of the individuals, going granular level is an important part of vaccine development, right? And we just said it. A lot of genetics, a lot goes into that. Now, going to the DVT part, I think I may be a little bit skewed of what I'm going to say on a cardiology perspective. We know respiratory failure and a cardiology failure is kind of go hand in hand. We also know there's a lot needs to be learned about the receptors, COVID receptors. I'm not sure you heard of ACE, ACE receptors too. There's a whole buzzword, people who take antihypertensive pills. So it may be worth looking as an hypothesis generating discussion. From a scientific perspective, directly a DVT versus having COVID symptoms may be correlational. There is some relationship, but I am hesitant to say anything more strongly causal relationships there. I hope I clarified that too.
All right, thank you for that. There's a question about public health literacy organizations and whether these types of organizations can help in situations like the COVID-19 pandemic.
Okay, so probably any one of you can jump in. I will take that because I am also part of the public health literacy organization, which we work at a global level. What we do is to learn from the mass, the ground level, end users level, collect the data and try to interpret more multidisciplinary, cross-disciplinary approach, like all of you have been saying, in order to tackle COVID, community engagement, their participation, their buy-in, while the scientists are working towards evidence-based is critical. So public health literacy organization, I guess this is a public health event, at least in Vega, I see that. And I am learning a lot. I mean, what Dr. Ghosh and Islam has mentioned, both the speakers, it made me think differently. I mean, One Health is making me think differently. And every speaker have added something. This is what I call it as public health literacy. And that's what we push all the time.
Thank you. Another question, a report of newborn babies testing positive by PCR for the virus. Is it possible that the virus has mutated fast enough to be able to avoid the placental barrier, get these apparently congenital infections?
I guess that question is for the virologist.
Again, publication data is very preliminary. Yeah, there has been cases in newborns, and like Kawasaki-like disease has been reported in newborn, and it has been, I'll use the word, associated with COVID-19. To my knowledge, based on what's available until now, and again, I may not be updated, is that apparently I don't know how mutation correlates with that. Yeah, that is something that needs to be looked into, but I don't think sufficient evidence as of now is available to corroborate that hypothesis.
Okay. Thank you. Question about climate change, either hot or cold. Does the increase or decrease in the temperature have impact on the growth or spread of the virus?
Basically, these are enveloped viruses, and normally what classical virology says is that if a virus has an envelope, it is usually fragile in extreme environmental condition, but that has always not been the case. And given the spike in cases in certain countries which are experiencing quite hot summer, such as the country from where I basically am, India, this is a difficult thing to comment.
We're asked if COVID virus can pass from humans to animals, either pets or wildlife. In Dominican Republic, people eat a lot of wildlife. And should we be worried about human to animal zoonoses creating new reservoirs for the virus as it continues to recombine and mutate?
There has been a few studies where which has been quite reported in popular media that COVID-19 has been detected in dog, cats, and captive wildlife. There was a study that was conducted where they inoculated various species of animal, and they found that ferrets and cats can support the replication of the virus. So apparently in dogs, the virus may not sustain, but their experimental data shows that ferrets and cats, Felidae, can sustain virus replication. So that is what information is available until now. And eating wildlife may not be a good idea because it's not only COVID-19, but it can facilitate the transmission of other viruses and other pathogens.
Yes. A question about whether the experience of veterinarians working with coronaviruses has been utilized very well to provide lessons learned for the current COVID-19 situation.
It is too premature to say that because the disease was basically the limelight that this disease has received is from early of this year. But yeah, as a veterinarian, I can say that although coronaviruses can be, of course, COVID-19 is very important, but there has been rare instances where coronaviruses have been reported in humans, especially, the SARS, MARS, and COVID-19. These are the three notable ones. But in animals, we do see coronaviruses, and coronaviruses are very diverse in animals. For example, in pigs, it can cause severe diarrhea as well as it can cause respiratory disease. In cattle, it causes severe diarrhea, respiratory disease. In dogs, it can be enteric or it can be pantropic, as I showed. In cats, it can cause diarrhea or it can cause systemic disease. So the pathology of coronavirus, the way the virus changes and the tissue tropism changes based on the changes in the virus. Of course, much of it is not yet established, but there is a strong hypothesis. And then, the immune response, especially in cats, which kind of we can draw an analogy with that of COVID-19. And then more importantly, vaccine, the ADE, the antibody dependent enhancement, and the pitfalls that we have seen with coronavirus vaccine in animals, that can be very important lessons, while designing therapeutics or prophylactics against COVID-19. So I said that there is a wealth of information, but it has not yet been properly cultivated. But again, you should understand that this virus is relatively new. But I feel that there is a wealth of information the veterinary sector has to offer, which could benefit the development of diagnostics, therapeutics, prophylactics, as well as understanding the pathology and the tropism of COVID-19, the SARS-CoV-2.
Thank you. There are a couple of questions about a vaccine. What is the likelihood of being able to develop a vaccine? And once we have a vaccine, what is the likelihood that people will actually accept being vaccinated?
Yeah, I'll take some, and I welcome my group to jump in. You heard it this morning. Dr. Anthony Fauci made a statement that cautiously is optimistic that a vaccine could be on the horizon by the end of this year or late
Early next year.
We have quite a few pharma companies are working on it. You know, Sanofi is working on, Glasgow is working on, everybody's working on vaccination. But we just to respect the process of vaccine development requires time. You know, it's phase one. In phase one, you need to look at the safety. Phase two, efficacy. All of this is being conducted. So based on Dr. Anthony Fauci, which is ultimate voice in this country, he thinks there could be a vaccine by the end of this year, early next year. And he's been very cautious about that. And because it takes time. So if you're asking me, I'm more hopeful that we'll have a vaccine, but it's not fair for mainstream to expect vaccine to be hand delivered in a matter of 6 months, not knowing what it will do to you in 20 years down the line. So speakers, please jump in, help me out.
I thank you for starting this, answering this question. But also I was following Dr. Fauci's information, and that made me very, optimistic that there will be vaccine. But when I looked into the process of vaccine production and also the history of RNA virus vaccines that we have, Dr. Ghosh is raising his hand. We don't have any good vaccine for RNA virus yet. Do you have anyone?
Yeah, I would like to jump into that. There are two important aspects to this. And of course, one should be very optimistic that we'll have a vaccine that will be very effective. One concern is what is the duration of immunity offered by the vaccine? As I shared some information from animal, like with feline coronavirus, the duration of immunity is very short. I don't know, means I have read material, and again, these are from the pre-published platform that people that were infected started shedding the virus after 80 days. So first question is, what is the duration of immunity that will be conferred by the vaccine? And secondly, there is a issue of antibody dependent enhancement. This has been seen in hamsters that had been tried with the MERS vaccine that is in development, but it has not been seen in mice. Where the neutralizing antibody binds to the spike protein and it facilitates the entry of the virus into the cell, and that aggravates the disease. Of course, this has been established in case of cat, where vaccinated cats develop more severe disease than control cat because of this antibody dependent enhancement mechanism. So these are the two things one should be a little bit cautious about. But I am very optimistic with the multiple technologies that we have available, and each of these vaccines is using a different approach. It should be good. One good thing is, like unlike segmented viruses, coronavirus is a single strand genome, and since coronavirus has proofreading mechanism, the rate of mutation in coronavirus is relatively less compared to other viruses because it has proofreading capacity. But on the other hand, another problem is the replication of coronavirus, especially COVID-19, is very aggressive and it goes very fast, which can compensate for the proofreading capacity with regards to mutation. But again, as all of us know, that many of the mutations are silent, and there are some of the mutations that may actually contribute to change in antigenicity. So we all hope that we have a good vaccine and it really works, and we come out of all this.
Yeah, I wanted to bring another dimension in terms of the timeline, and we all are hopeful, especially those who are working in the health sector. The other option is because of the hype of the pharmaceutical company. They want to make money, and they are coming up with, I'm giving one example. Moderna is one company whose share was $25, $6. Now they're going up to $80. And then they found out that they are giving false information in terms of the timeline. So they are being investigated because they're giving the false timeline. So I'm optimistic, but I know the human have a different dimension and characteristics. So as Dr. We all agreed that vaccine production is a time consuming. It takes time. Phase 1, phase 2, phase 3, and all those kind of things. even we have a vaccine, let's say hypothetically, we have a vaccine approved by next year, early next year, making available vaccine for that all the millions of people globally is not going to be 1 or 2 years action. Everybody will not get the vaccine that quickly.
And then also there is the issue of vaccine side effect, and this is not related to coronavirus, but related to virus I have been working on for the last 15 years, that is rotavirus. The first vaccine that came out from the US was Rotashield. The vaccine was doing good, but then there were sporadic cases of intussusception and the vaccine had to be withdrawn. So although the vaccine was efficacious, but just because of some cases of intussusception, the vaccine was withdrawn. So that is another thing that that we should look into once the vaccine is in the market, and we pray that there are no such side effects.
Thank you all for those comments on the vaccine. There's another question about nutrition and how eating well would make people less susceptible to COVID-19 infection. Can anyone comment on that point?
Okay.
No idea.
Eating well probably will make less susceptible to all the human diseases that we know of. That I can confidently put it out there. Yes, from a scientific perspective, I don't know if we can tease it out to a granular level and tell them if you eat this well, this is the percentage you reduce risk-wise, right? I mean, you have to stratify that and study the significance, as is something that I've not read when it comes to diet. But overall, staying fit, comorbidity risk factors, obesity, hypertension, diabetes, they're all related to poor diet, right? High salt, high fat. So I could indirectly relate that discussion. Having said that, we don't have enough data to kind of put it in a box. You eat this healthy, here you go. You will not get a COVID. It's hard. That's all. Gentlemen, please jump in.
Yeah, I think the eating healthy diet keep you healthy overall. Your immune system may be a little bit effective compared to fighting the virus, but from the perspective of virology and immunity, I think we have not enough evidence right now. As Dr. Prasad mentioned, that we can identify, okay, eat X, Y, Z, you will be good to prevent the disease, or even if you get the disease, you will have less, impact of the disease. We don't have that evidence, but it is always good to have good habit, to have good diet, so that you can reduce the other risk factors, which has very significant impact on this disease severity and mortality.
As you said, Dr. Islam, I want to go back what you said. It is not that we are kind of pessimistic or speaking in more non-hype way. We as a scientific committee should control this hype, right? The moment one journal puts out, if you eat 10 bags of tuna or peanuts, next day the entire market will crash. The stock market will go crazy, supermarket will be flooded. We've been through that several times in the last 3-4 months. So comforting them that there's no reasons to come up with just because you want to hear it from me.
Yeah.
We cannot cater to that without strong validity, and it actually traffics more of unnecessary tension in the society.
Yeah, I agree with that. But one of my personal, experience with the diet, you can see how many times we came out with, oh, this is good for you. And then after a few 10, 15 years, a big study came out, oh, egg is not, now egg is good. Before it was high cholesterol, you cannot eat it. So the diet is such a thing. The way I take it, we can eat everything healthy, eat moderate, that will keep us healthy. Nothing, if someone says one study came out and says, look, if you take high fiber, you will be good. But high fiber alone will not keep you healthy and prevent your colon cancer. So you have to take it in a context and use, in moderate way. And diet is one thing I take, that no diet, even the ethnic diet different ethnic group they're using, because they're using for millions of years. And there is an evolution. They have their body and things can be adopted with certain kind of diet, and moving them from that diet to a completely new diet, it drastically may not be good for them either. So it's a diet is a long-term habit, and we have to start and get used to with our own habit and make sure that we eat healthy and in moderate all the time.
Further to that, a question is about certain foodstuffs, such as fruit like lemon, also ginger, or other ways to prevent infection. For example, hot water with menthol, and then, breathing the vapor from that, or also using bicarbonate of soda. Do those things help prevent infection?
I had a slide in my presentation. I intentionally put that slides because, as I said, internet is a blessing to us, but at the same time, it quickly translate all the misinformation that is myth. It doesn't help, and I would recommend the who asked the questions. I will send my slides to you and Dr. Cruz to distribute to the people, that at least they can look into that whole paper out there that shows these are myths. It really don't help to prevent or acquisition of the disease, especially COVID-19.
Some questions about treatments that can prevent progression of the disease. I think there was just some information about dexamethasone that came out. Can you expand on that?
I have not completely read, but the information I have that low dose dexamethasone can help boost the immunity, and the study that came out that they have in terms of the duration of the disease and mortality was statistically significant lower. The group had that. If one of you has the information specific to the paper published, anyone has it?
I don't have specific information, but as it goes that if there is a strong immune reaction, as we see in case of COVID-19, where there is a cytokine storm and stuff like that, then of course using a steroid with a low dose or a tapering dose will help to subdue the inflammatory reaction, and it will prevent any immunopathology mediated damage to the organs, which is kind of a sequelae to the COVID-19 per acute cases.
I think
So
this
that may be
paper came out from Cambridge.
Okay, yeah, means I think that may be the basis of using dexamethasone to subdue the euphoric inflammatory immune system.
The way we call the overreaction of immune system.
Okay. There are a couple of people with their hands up, but I think we're out of time now. Is Professor Cruz there?
Yes, very good presentation to all of you, and really thank you and congratulations because you make it on time. Just 1 minute before than the time that we were planning to finish. Of course, we take the break out of the program. So because we didn't have a section question and answer, but it was really great done by Professor Willingham, and really thank you very much to Professor Prasad for participation today, and we hope we're going to have a collaboration with all of you. Professor Islam, Munro Islam is collaborators of the impact. He's associate professor, associate researcher already for more than 10 years too. And he is very accustomed to come to the Dominican Republic. Sometimes he has been here 2 or 3 times a year. So we are missing you this year, Professor Islam. We hope next time you will come. of course, Professor Prasad, we are going to make a special invitation the next year when we have the Congress organized by the Ministry of Higher Education. Ghosh, also, you are from our group, and expect that we already have two projects going on about One Earth with the Rose University, and leading on that project, mainly by Professor Willingham. But you belong to our team, so really thank you very much. Very passionate your presentation, very touching your presentation, and make us to feel like the passion for biology and One Earth. Really thank you very much to all of you, and we have to move to the other section, to the other panel that already they are waiting for us to put on this. Too many questions, very good answer, and I am really very happy. I know that Ministry of Higher Education and especially the Vice Minister of Science and Technology is very glad of your participation today in this panel. Thank you again.
Thank you so much. And thanks to all of you.
So long.
Bye.
Bye, Professor Lee, and
bye-bye, everyone.
Bye-bye.
I just wanted to mention that I have been working with One Health in Rwanda.
Oh.
we didn't know that.
You didn't know that?
Yep.
All right. Goodbye now. Talk to you later.
Yeah,
bye-bye.
take care. Bye-bye. Stay safe.
Bye.
And the new panel is going to be very, the final panel today is going to, excúseme, déjeme hacer el shift. Va a ser el tercer panel del día, en el día de hoy. Y en verdad, para nosotros es un gran honor tener a todos los participantes cautivos, tratando de, y activos en la participación de este simposio. En realidad agradecemos a todos los que están presentes y que vamos a compartir estos minutitos más para... me falta Carlos Rodríguez. Bienvenida, doctora Zunilda Núñez, desde la ciudad de Santiago y de Cicloclic, allá en el hospital de Santiago, siempre haciendo investigaciones de interés. Haga una prueba de voz, por favor, a ver si lo podemos escuchar.
Muy buenas noches, ¿me escuchan bien?
Sí, le escuchamos muy bien, doctor.
¿Se ve la imagen adecuadamente?
Sí,
y
sí.
Excelente día. Realmente hemos aprendido muchísimo. Y ahora,
Gracias.
y el orden de las presentaciones
Sí.
va a ayudar
Vamos a esperar que Carlos, a ver si, porque él el primero pienso que debe de presentar, ¿no?
Él me confirmó que ya está dentro. Entonces
ya está dentro.
A ver si tú lo puedes decir. Se escucha perfecto, me dice.
Sí, escuchamos muy bien.
Carlos está ahí.
Carlos está, ok.
Estoy aquí, estoy.
Excelente. Muy bien, y ya
no
te
le
veo.
vemos en el video, pero lo vemos en la foto estática suya.
Bueno, espera, déjame ver por qué.
Tiene que poner el video, por favor.
Pero no veo por qué.
Bueno, en esa foto él se ve muy bien.
Pero no sé
la
por
verdad,
qué no.
doctora, que unos años menos parece, ¿no?
No, pero está muy...
Carlos,
ya está.
Okay.
Ya estamos, bien, muy bien,
Okay,
excelente.
Carlos, excelente. Bueno, vamos a iniciar el último panel de este día y está relacionado principalmente con dos elementos importantes. La mañana hablamos sobre el diagnóstico, cómo mejorar el diagnóstico, cómo hacer un diagnóstico rápido y ver las otras posibilidades de que podamos utilizar, especialmente en momentos de pandemia y con un alto nivel de participación de los científicos de diferentes áreas. Ustedes vieron en la mañana con la participación de Pelechano, de Karolinska, con la participación de Leonardo de Silva, de Chile, y al igual que participó la doctora Irene Bosch de E25Bio, un laboratorio de punta, generalizado, focalizado en lo que es las pruebas rápidas. Pero también estuvo la doctora María Isabel Veiga de la Universidad de Minho en Braga, Portugal. Carlos también ha estado visitando esa institución. Lo sabemos que haya ido allá por visitas científicas y de organización de unos proyectos que tenemos. Ella también explicó cómo modificaron, transformar un laboratorio de investigación en un laboratorio clínico. Entonces, esa es una alternativa también que nosotros debemos ir pensando, doctora Núñez, para cuando nos toque las partes de investigación, ver cuando ocurra una pandemia o quizá en esta misma, podríamos nosotros reaccionar de la misma forma que ellos lo han hecho. Entonces, acabamos de ver ahora el abordaje o la actualización de cómo está la pandemia, vista desde el punto de vista de especialistas científicos en el área de salud pública, y al igual que los exponentes sobre la salud única o One Health. También, o sea, esperamos que ahora, a finalizar de este último panel, es con relación al abordaje posible terapéutico o alternativas que tenemos de terapia sobre COVID-19, y también aquellas personas que, aunque no estén positivos, también están afectadas por razones del nivel mental. Y para eso tenemos los grandes exponentes, tanto el doctor Carlos Rodríguez, yo sé que la doctora Zunida la va a presentar, que es un infectólogo con muchos años de experiencia, y al doctor Solio Emilio García, de la Universidad Pontificia Universidad Madre Maestra, allá en Santiago. Entonces, es un gran placer para nosotros tenerlo. La doctora Zunilda Núñez no necesita presentación en lo que es el marco de estos tipos de simposios organizados por el Ministerio de Educación Superior, Ciencia y Tecnología, porque tienes años trabajando en el comité organizador con este tipo de organización. Sabemos que en el día de hoy usted estará amando de concluir este último panel. Por lo tanto, como moderadora, nosotros simplemente vamos a estar aquí acompañándoles. A todos ustedes les dejamos con la doctora Zunilda Núñez. Adelante, doctora.
Micrófono.
El micrófono, doctora.
Muchísimas gracias, Modesto. Es un honor estar aquí colaborando con este aporte tan valioso del Ministerio de Educación Superior, Ciencia y Tecnología. Y escogieron para el panel final a dos experimentados profesores. Uno en el área clínica, que tiene más de 20 años trabajando en el Hospital de las Fuerzas Armadas, no solamente viendo pacientes, sino asumiendo responsabilidades de gestión y de liderazgo, ya que ha estado encargado tanto del Departamento de Medicina Interna y ahora está como jefe del Departamento de Infectología, y también es encargado en el Hospital Heriberto Peter, y siempre aportando con los programas de residencias médicas. Y tiene la importante particularidad que queremos que cada vez se haga más frecuente en la República Dominicana, de ser un clínico en la práctica que aporta y toma tiempo para generar datos científicos que faciliten rápidamente tener información válida. Incluso va a hacer un interesante análisis de los datos que se tienen para el tratamiento de los pacientes con COVID-19 en cada una de las etapas, y también va a hacer algunas observaciones sobre los pros y los contras de los diferentes tratamientos propuestos. Doctor Carlos Rodríguez, el espacio es suyo. Más adelante ya presentaré quien abordará el otro aspecto importante del ser humano, que es la salud mental, fundamental para que se tomen decisiones correctas, que es el doctor Saibo García. Adelante, doctor, y muchas gracias por su tiempo.
Gracias, Unilda. Gracias por la presentación. Y para mí es un placer estar entre amigos, entre personas que realmente les tenemos mucho afecto y que estamos conviviendo dentro de un ambiente científico desde hace unos añitos. Bien, me toca exactamente hablar de la parte clínica y de lo que tiene que ver con el tratamiento. Vamos a ver acá. Ok. Se ve la pantalla, ¿verdad? ¿Aló? ¿Se está viendo la pantalla?
Sí, se ve bien,
Sí,
Carlos.
perfecto, ok.
Se ve perfectamente.
Bien. Ok. Entonces, en este panel que básicamente discutimos un poco sobre el manejo de la enfermedad del COVID-19 y la pandemia, nos toca pues hablar de las alternativas terapéuticas y quizás de las modalidades de tratamiento que están mucho más en el tapete, porque si vamos a hablar de todas las alternativas que hay hoy en día, todos los estudios y modalidades y moléculas que están siendo investigadas, pasaríamos días en esto. Quiero decir que no hay ningún conflicto de intereses. Lo que hablemos aquí es medicina basada en la evidencia. Y queríamos comentar que desde el punto de vista de la pandemia, lo que vemos normalmente es el iceberg, es la punta del iceberg. Quizás en lo que hablamos de datos, de muerte, de enfermedad severa y de detectado, porque la mayoría de pacientes, el 80%, va a tener un cuadro leve y muchos de ellos, aún sin pruebas o con pruebas, no van a ser detectados por la parte clínica. Entonces tenemos 80% de casos leves, con quizás un 15% de personas que tengan que hospitalizar, que sería la punta del iceberg, y un 5 a 6% que son los que van a la terapia intensiva para precisar de ventilación mecánica. Es decir, que tenemos la gran mayoría dentro de cuadros leves. En Dominicana, pues el reporte de hoy nos habla de quizás casos en total positivos de unos 27,000, con unos fallecidos en total en 675. Sabemos que el subregistro puede estar presente y no solamente en nuestro país, en muchos pacientes, porque es muy difícil que se pueda tener una data actualizada, pero importante que nuestra tasa de letalidad se mantiene relativamente baja comparado a lo que sucedía inicialmente en los primeros tiempos de la pandemia, donde no teníamos más pruebas para realizar, y la medida que se ha ido cotejando, pues tenemos una tasa de letalidad hoy en día de 2.42. Sabemos que ha habido un repunte en medida que se abrieron a las fases de desescalamiento para la actividad económica y social, y esto ha traído como consecuencia que aumente el número de casos independientemente de que las personas no llevan a cabo las medidas trazadas de distanciamiento, el uso de mascarilla y el lavado de manos. Entonces esto quizás no sucede solamente en Dominicana, en muchos países esto ha sucedido por la apertura quizás precoz y es el miedo que la OMS o OPS había tenido anteriormente. Pues hablamos de que en la replicación viral muchas de las moléculas que conocemos actúan a diferentes momentos. Pues sabemos que los antivirales van a estar presentes en la primera parte de lo que es la replicación y posteriormente en lo que se refiere a la multiplicación o a la conversión del genoma de ARN en ADN en la molécula del individuo, y ahí quizás que tengan algún efecto estas moléculas. Todavía en este cuadro vemos la cloroquina, hidroxicloroquina con una cierta acción antiviral, pero que hoy en día sale bastante del firmamento por muchísimas razones que veremos más adelante. A distintos pasos de la replicación es que veremos las distintas moléculas antivirales, el favipiravir, el remdesivir, y por último tenemos aquellas moléculas inmunomoduladores que actuarían básicamente en lo que es la tormenta de citoquinas que se desarrolla durante el proceso infeccioso a una respuesta de la actividad del proceso viral. Ok. pero cada fármaco en su momento según el estadio de la enfermedad. ¿Por qué? Porque no todos los fármacos actúan al mismo nivel y esto trae como consecuencia que si vamos a utilizar todo al mismo tiempo sin ningún tipo de criterio, económicamente sería prácticamente inviable el tratamiento de la enfermedad. Sabemos que las fases de la enfermedad están divididas y donde hay en la primera parte, en el estadio 1, una gran actividad viral con una infección temprana, y luego un estadio 2 con una fase pulmonar que dividimos en 2A y 2B, donde ya comienza a bajar lo que es la replicación viral y comienza a instaurarse una gran respuesta inflamatoria que podría llevar al individuo hacia ese estadio 3 hiperinflamatorio, donde hay una liberación de una cascada de moléculas de citoquinas que pueden ocasionar mucho daño en el organismo. Entonces, como le comentaba anteriormente, si tenemos 81 casos leves que no van a necesitar prácticamente nada, como yo digo, cama, cariño y líquido, y si tuviera algún síntoma, un acetaminofén o un paracetamol. Un 14% que serían los severos y los críticos que serían en los que verdaderamente tendríamos alguna acción de tratamiento o terapéutico. En esta parte de tratamiento tenemos un montón de drogas, desde antivirales, desde antiparasitarios, todas ellas que se han puesto en el tapete en algún momento para tratar la enfermedad como tal. Los interferón, los mismos inhibidores de interleuquina y todo esto de una manera, como sabemos, estamos haciendo camino al andar porque una enfermedad que se conoce pues en poco tiempo, un virus nuevo, pues obviamente que todo el mundo intenta hacer algo. Todas estas terapias se han utilizado, pero hay una necesidad de hacer pautas prácticas actualizadas con frecuencia, porque como siempre digo, lo que hoy puede ser la gran mentira, mañana puede ser la gran verdad y viceversa. Por tal motivo, la Sociedad Americana de Enfermedades Infecciosas pues tiene unas guías de tratamiento que va actualizando frecuentemente exactamente para poder trazar estas pautas y que todo el mundo vaya teniendo un manejo homogéneo. El mismo Instituto Nacional de la Salud de Estados Unidos, pues a la rápida evolución de la pandemia y la ausencia de tratamientos exactamente aprobados en sentido general, excepto el Remdesivir para la FDA, pues han emitido muchas pautas de tratamiento por esta razón. Realmente para cuidar bien de los pacientes y para que la información que va evolucionando rápidamente se vaya actualizando. Farmacológicamente, para ciertos tratamientos seleccionados, tenemos aquí un resumen y colocamos algunas drogas que están exactamente en uso. El Remdesivir, el Favipiravir, el Tocilizumab como inhibidor de interleuquina 6 para la tormenta, y ahí tenemos todavía la hidroxicloroquina y la hidroxicloroquina que realmente van a caer muy por fuera porque todos los estudios muestran que no exactamente tienen ese poder importante que se le dio y que traía algunos efectos adversos que pudieran traer como consecuencia más daño que beneficio. Todavía en nuestros países es una arma que se tiene todavía en uso por la carencia de otras moléculas que no han llegado acá. Y todavía vemos que el uso de hidroxicloroquina persiste porque realmente a falta de nada, bueno, pues vamos a echarle a lo que alguna evidencia en algún momento ha tenido. Los antirretrovirales por igual, con menor capacidad de uso, y otros antivirales que realmente no han estado en el armamento de drogas. Si hablamos de la hidroxicloroquina, dice la Organización Panamericana de la Salud que hay una evidencia suficiente sobre los beneficios de la hidroxicloroquina y la gran mayoría de investigaciones hasta el momento no sugieren ninguno. Es decir, que todo lo que se ha recopilado hasta ahora se ha puesto en una balanza y no se observa ningún beneficio. Incluso algunos estudios con baja calidad metodológica, hay cierta evidencia acumulada del daño del uso de la hidroxicloroquina y sin diferencia en el impacto de la mortalidad por todas las causas de los pacientes. Fíjense que en un momento dado, todo fue un boom cuando salieron varios artículos hablando del gran daño que hacía la hidroxicloroquina y la cloroquina, para después unos trabajos que no tenían una base robusta, hubo que ser los autores retractarse y las revistas retirarse, tanto la revista Lancet como la revista New England, que habían publicado estos estudios llenos de sesgos que en un momento dado nadie entendía que buscaban allí. Después tenemos estudios randomizados utilizando la hidroxicloroquina como profilaxis posexposición, algo que se ha estado usando en Dominicana también sin ninguna evidencia. Y se consiguió conocer que realmente como profilaxis, como prevención, después que alguien se expuso o por su trabajo o por su condición de alrededor, no tiene ninguna evidencia en la utilización de profiláctico de la cloroquina. Por tal motivo, la FDA acabó revocando la autorización del uso de emergencia de la hidroxicloroquina y la cloroquina, que como sabemos son drogas antiparasitarias, antimaláricas, y se le había dado autorizado el uso para tratar este tipo de pacientes. Vemos cómo se van cayendo del pedestal muchas drogas que inicialmente tenían un gran boom. Tenemos el lumefanidine, que es un antiviral prometedor porque ha dirigido tiene una interacción e inhibe la fusión de la membrana de la envoltura y ha sido probado en unos estudios en Rusia y China para tratamiento y profilaxis de influenza. Es mucho interés que se haya utilizado en COVID-19 con algunos datos in vitro, con una dosis de 200 miligramos cada 8 horas para la gripe. Se ha estado estudiando totalmente para el COVID en estos asuntos, pero todavía es muy precoz para decir, porque es una experiencia muy limitada con lo que se escribió en China. Algunos estudios se asociaron con tasas de mortalidad más bajas y tasas de alta mayores que los pacientes que no los recibieron, pero todavía se carece de estudios más robustos, de randomizados y controlados para poder hablar de las ventajas. Sin embargo, con el favipiravir, que es un agente activo que tiene la replicación viral, pues vemos que ya tenía algunos datos preclínicos con influenza, con ébola, y se demostró que tenía esa actividad sobre los virus ARN, como el SARS-CoV-2, y varios regímenes de dosificación se han propuesto exactamente para tratar de conseguir inhibir la replicación. Los rusos hoy en día han rescatado, porque la molécula es una molécula japonesa, pero los rusos en los últimos tiempos han mostrado algunas ventajas, recomendando dosis importantes y tiene una ventaja que es vía oral. Tiene efectos adversos leves, aunque el perfil de evento para regímenes de más altos es limitado, pero realmente en Japón ha sido una droga que se ha utilizado desde hace tiempo para tratamiento de influenza. Lo único que no está disponible en Estados Unidos para uso clínico. Sin embargo, vemos que hay estudios clínicos que están corriendo ahora mismo viendo la eficacia del favipiravir, ya sea solo, combinado con un inhibidor de interleuquina o comparado con el arbidor en estudios randomizados. Veremos qué sucede con estos resultados, que es lo que nos da una base para poder utilizar todos estos medicamentos. El remdesivir es un profármaco que realmente sufre un metabolismo y se convierte en un metabolito activo, que es el trifosfato de adenosina, y fue descubierto en un proceso de búsqueda de antimicrobianos contra virus ARN, coronavirus, flavivirus. Y la investigación ha mostrado anteriormente un compromiso importante contra ébola, y actualmente es una terapia que promete bastante y que los estudios que han hecho, los preliminares de los estudios randomizados también. En modelos animales ya se había visto que era la infección pulmonar en MERS prevenía la hemorragia pulmonar, y la dosis actual se da una carga de 200 miligramos seguido por una infusión diaria de 100 miligramos intravenosa. No se recomienda en inicio en pacientes con estimada tasa de filtración glomerular inferior a 30 ml, pero el monitoreo es importante porque puede haber flebitis, estreñimiento, cefalea, prueba de función hepáticas alteradas, y como está coformulada con psicodestrina, pues puede haber un riesgo acumulado de insuficiencia renal, tal como sucede con las lesiones renales ocasionadas al voriconazol intravenoso. Estudios preliminares que fueron en ensayos donde se usaba el uso compasivo, se vio una muestra importante donde había pacientes de alta, la mayoría cuando se utilizó en Chicago, con poca mortalidad. Estos estudios compasivos nos mostraron mejoría clínica en 36 de 35 pacientes, un 68%, y eso da el traste a los estudios más correctos, mejor trazados, mejor proyectados, como el estudio adaptativo que se comenzó en la Universidad de Nebraska y que tenía un brazo en China, tanto en Beijing como en Wuhan, y que trajo como consecuencia que esto nos diera alguna información más acabada. Un análisis preliminar mostró en pacientes que no requerían oxígeno ni hospitalización, en un 31% más rápido en los que utilizaron remdesivir que placebo, y la tasa de mortalidad de 8% los que usaron remdesivir comparado con 11% a los de placebo. Eso fue, el fabricante informó que el curso de 5 a 10 días en la medicación fueron igualmente eficaces. Por tanto, básicamente se está utilizando actualmente por solamente 5 días. Y eso le dio como consecuencia que la FDA aprobara el remdesivir como una droga para tratar el COVID-19. Los antirretrovirales, pues obviamente están aprobados para el uso en el VIH y tienen alguna acción sobre estos virus ARN. Ya se había visto en SARS y MERS que esto podía ser importante, y un régimen utilizado en algunos estudios mostraron algún grado de mejoría en los pacientes. Sin embargo, otros estudios lo tiran por el suelo, hablan que no hay ninguna diferencia y realmente la data es muy controversial. Tanto que la Sociedad Americana de Enfermedad Infecciosa y la Instituto Nacional de Salud de Estados Unidos no recomiendan el lopinavir, ritonavir como otros inhibidores de proteasa del VIH fuera de los ensayos clínicos, igual que otros antirretrovirales como el darunavir, covicista, que en un momento se utilizó en algunos estudios en China, y otros antirretrovirales también. Sin embargo, no es una droga que se tiene muy a la mano comúnmente en nuestro país tampoco, aunque está en el programa, en el protocolo nacional. Fuera de esto, como monoterapia, un estudio que lo mezcla con ribavirina y con interferón beta, pues sí mostró que esta triple terapia podía tener un acortamiento en la duración de la eliminación del virus y la estancia hospitalaria en este estudio, por lo que se justifica hacer otros estudios con doble terapia antiviral para ver si realmente su acción sola no es muy favorable, pero en combinación con otros agentes sí lo sea. Desde el punto de vista de los antiparasitarios, vemos como la ivermectina, que fue una droga que casualidad por una tierra que se tomó de un campo de golf, el doctor Satoshi Omura pudo accionar, aislar junto con el doctor William Campbell la molécula a partir de un estreptomice, y es muy importante ver cómo este producto antiparasitario ha cobrado mucha vida en los últimos tiempos, que es seguro, que es eficaz y que tenía acción sobre el SARS, la rabia, influenza, VIH, dengue y todo esto. Básicamente lo que más le dio potencial para el SARS-CoV-2 es un estudio que salió publicado en marzo de 2020 de los investigadores de la Universidad de Monash en Melbourne, Australia, donde consiguieron ver que la ivermectina podía alcanzar, inhibir completamente y matar el coronavirus en menos de 48 horas. Realmente aquí se ve en este gráfico importante que se consiguió la caída importante del RNA y la replicación viral. Sin embargo, más adelante otros estudios hablan que la concentración media simulada de ivermectina no se conseguiría absolutamente nada con la droga y la dosis que se da por vía oral para matar los parásitos. Es decir, todas estas líneas nos muestran que muy por debajo de la línea roja, que es la línea que inhibe el 50% de la replicación viral del SARS determinada por el estudio in vitro, ninguna de estas dosis consiguen llegar cerca de lo que sería esta dosis que se alcanzó in vitro. Por tal motivo es que no está colocada como tal dentro de los parámetros, porque no existe una evidencia robusta en humanos. Otros estudios han hecho con la ivermectina coformulada en una presentación de acción prolongada que ya se tenía presente para trabajar en unos estudios de malaria, y en lo cual se ha invertido para tratar de ver si de manera coadyuvante pudiera ayudar en la prevención, puesto que ya se había visto que tenía alguna acción en la replicación in vitro sobre virus como el virus de dengue, incluyendo hasta el propio VIH, pues obviamente esa seguridad y eficacia contra estos virus pudiera ser extrapolada. Sin embargo, estos estudios actuales no tenemos ninguna evidencia que nos hable de que en el SARS-CoV-2 esto pueda ser igual que con estos otros virus. Por igual también tiene el problema de que no es segura durante el embarazo y por tal motivo no se respalda su uso en este tipo. Sin embargo, la FDA aprobó su uso para los estudios en SARS-CoV-2 y actualmente hay muchos estudios corriendo con diferentes dosis, porque la dosis habitual que se utiliza para parásitos aparentemente es una dosis muy baja y vemos estudios que están en carpeta que muestran que sí. Hay unos estudios no publicados y que realmente por coincidencia son de los mismos autores que tuvieron que retractarse con el estudio de hidroxicloroquina que mostraban que era maravilloso. Sin embargo, nunca fueron publicados y por tal motivo su respaldo como bibliografía realmente es muy cuestionado. Fíjense ahí, muestra una importante reducción y una sobrevida importante de los pacientes que utilizaron. Sin embargo, no son tomados en cuenta por esta razón. En Miami, algunos ensayos que han sido realmente observacionales, pues han mostrado algún beneficio asociándolo en ese momento a hidroxicloroquina, citromicina, sulfato de zinc y ivermectina. Realmente con estos cócteles hay que tener mucho cuidado porque pueden dar una falsa sensación y no se sabe exactamente dónde estaría la actuación y si es en casos leves, pacientes que pueden tomar medicamentos orales, pues es muy difícil saber si el caso leve se va a resolver por sí solo o con el uso de las drogas. Aquí vemos cómo el potencial, la ivermectina como un potencial desde el punto de vista, se ha visto que los puntos finales de actividad antiviral se analizan desde una perspectiva farmacocinética y la dosificación clínicamente relevante y excesiva indica que esas concentraciones que se utilizaron in vitro no serían posibles en humanos. Entonces, esto hace que todavía se tenga más miedo de pensar que si la droga por sí sola habría que tener de 10 a 35 veces la dosis que se utiliza como antiparasitario, pudiera ser una dosis que no se pueda utilizar en humanos. De ahí que he estado utilizando y sin embargo la FDA ha advertido por algunos ensayos y algunos estudios no autorizados o no éticos donde se utilizaba la ivermectina de uso veterinario, realmente a advertir que realmente la ivermectina de uso veterinario no es para el tratamiento del COVID-19 en humanos. Entonces, ojo con esto. Ahí tenemos dos grandes estudios que se están corriendo en Estados Unidos, que es el de la Universidad de Kentucky, que está actualmente reclutando pacientes donde tenía embarazos diferentes como la hidroxicloroquina, la hidroxi con acitro, hidroxicloroquina e ivermectina y el mesilato de calmostato. Sin embargo, el estudio de la Johns Hopkins, que tiene realmente una dosis triple de la que se utiliza como antiparasitario de ivermectina, es un estudio que todavía no ha comenzado a reclutar pacientes. Tiene varios brazos con bicalutamida y el estándar de atención para comparar y poder tener una conclusión en estos estudios. La fundación de Bill Gates pues ha invertido un dinero para ver si esa como formulación de acción prolongada de ivermectina que se estaba implementando o en estudios para malaria pudiera combinado la ivermectina con nitazoxamida pudiera ser utilizada como preventivo para el SARS-CoV-2 en unos estudios en África. De ahí es que la propia OPS ha lanzado una advertencia de la ivermectina no debe ser usada realmente en el tratamiento del COVID-19, porque no hay evidencia robusta para esto. Otro antiparasitario que se ha mencionado mucho en distintas partes del mundo es la nitazoxanida, porque se identificó como un medicamento que tenía un espectro antiviral amplio, ¿no? Primero en su clase y se había evaluado para el tratamiento de influenza en algún momento, porque se consiguió ver inhibición de replicación viral y que el metabolito actuaba selectivamente a la maduración de la hemaglutinina viral de la gripe, afectando realmente el tráfico intracelular de la hemaglutinina y la inserción de esta proteína en la membrana del huésped. Sin embargo, hay estudios que muestran que el uso en enfermedad respiratoria aguda no redujo la duración de estancia hospitalaria ni siquiera en pacientes con procesos de influenza. Entonces, hay mucha tela por donde cortar con la nitazoxanida, viendo que esos estudios realmente no se mostró absolutamente nada. Un estudio que muestra la comparación y el uso concomitante de nitazoxanida con acitromicina, que se había sugerido, pues se recomienda esta administración combinada, pues el autor pues había sugerido que se probaran más ensayos con interferón para ver si la combinación pudiera tener una acción potente contra el SARS-CoV-2. En Brasil hay una investigación con nitazoxanida que podría correr rápidamente utilizando 600 miligramos comparado con placebo. Llegamos al estudio Solidaridad, que es el estudio de la OMS, un ensayo aleatorizado para evaluar tratamientos no permitidos o hasta ahora no autorizados para COVID-19 en pacientes hospitalizados que reciben tratamiento convencional para el COVID-2 que se ofrece en cada hospital. Sin embargo, vemos como los brazos que tenía el remdesivir, cloroquina, hidroxicloroquina, lopinavir, ritonavir o lopinavir más interferón beta, realmente el brazo de cloroquina e hidroxicloroquina fue retirado del mercado. Y la OMS definitivamente, aún aquellos estudios se retractaron los autores, les sugiere que no resulta en una reducción de la mortalidad y por tal motivo ese brazo se retiró del estudio de Solidaridad. Tenemos la terapia basada en plasma, que sería una alternativa también como tratamiento y que ese plasma de convaleciente ayudaría quizás como terapia experimental a poder recuperar los pacientes administrándole este tipo. Como no hay un momento actual esa terapia específica tan robusta que nos haga olvidar de todo el resto, pues obviamente la terapia de plasma convaleciente, que es algo que se utilizaba hace mucho tiempo, pudiera ser importante. Igualmente, otras drogas como inmunomoduladores que pudieran ser utilizados, y realmente la FDA publicó una guía para que se pudiera utilizar el plasma de pacientes convalecientes para poder tratar pacientes de este tipo. Hay muchos criterios, muchas universidades con estudios montados para tener, pero casi todas coinciden en pacientes que ya tuvieron la enfermedad y que ya hayan recuperado durante más o menos 14 días después de los síntomas. Muchos estudios, como verán aquí, corriendo exactamente sobre el plasma, porque es una modalidad muy práctica y muy segura. Dominicana tiene una resolución, el Ministerio de Salud, para establecer los parámetros y las condiciones para el uso de plasma hiperinmune como tratamiento del COVID-19, que es importante y que también tiene la necesidad de pasar por un comité de ética y el CONAVIUS para poder aceptarlo. Últimamente oímos hablando de los corticosteroides y toda hasta la rueda de prensa de la presidencia, el uso de la dexametasona, y todo esto viene a partir de los primeros datos o los primeros reportes del estudio Recovery de la Universidad de Oxford. Realmente que en dosis baja ayudó exactamente a los pacientes hospitalizados con complicaciones severas. Esto realmente no está publicado en ninguna revista, simplemente es la primera nota que emite los investigadores de este estudio, y por tal motivo en algunos países todavía no es una conducta este uso de dexametasona, porque sabemos que si inicialmente se prohibía lo de esteroides, ya en los últimos tiempos se vio fuera de China que el uso de metilprednisolona y la hidrocortisona eran benéficos en una etapa de la enfermedad, pero no la dexametasona, que simplemente se ha estado utilizando en este ensayo y que ha mostrado realmente una reducción de muerte, un 35% de pacientes ventilados y un 20% en otros pacientes que recibieron oxígeno solo. Sin embargo, no se observaron beneficios en pacientes que no requirieron intervención respiratoria. Por tal motivo, su uso, que es una droga que tiene sus efectos adversos, una droga de uso delicado, porque ya vemos que a partir de las ruedas de prensa desde el Palacio y la salida en los periódicos, todo el mundo anda comprando dexametasona como si fuera una acetaminofén. Y ojo con esto, cuidado con los diabéticos, cuidado con personas que tienen problemas endocrinos. Los efectos adversos de la dexametasona pueden ser bastante serios para estar utilizando de manera prescrita, ¿no? Las vacunas, sabemos que hay varios ensayos de vacuna, pero rápidamente hay unas 6 diferentes ensayos, unos con ARN, otros con el ADN, unos con proteínas recombinantes, otros utilizando vectores como otros virus, unas vacunas de virus vivo o virus atenuado y otros utilizando subunidades antigénicas, una o más antígenos. Vemos que una gran parte de ellos estarían listos para salir en el último trimestre del año, de este año. Y de ahí en adelante vamos a ver cuál sería la eficacia de estos productos para poder masivamente tener si realmente no hay efectos adversos importantes y su eficacia sea recomprobada. Por tal motivo siempre digo que no hay nada que enseñe más que equivocarse. y el trabajo en equipo en este tipo de patología se hace necesario, pero siempre apegados a la ética y a las buenas prácticas clínicas que se debe llevar en los ensayos clínicos. Jamás fuera de la ética utilizar productos para tratar esta enfermedad, aunque estemos en pandemia y aunque se estén utilizando de manera indiscriminada. Así que muchísimas gracias.
Muchísimas gracias, doctor Carlos Rodríguez. Al igual que han hecho en los otros paneles, vamos a hacer la sesión de preguntas al final y ahora vamos a darle paso a la presentación muy interesante, su resumen sobre las diferentes alternativas que tenemos que ver. Muchas preguntas para saber cuándo y cómo y qué usar, qué usted está haciendo en su práctica. Eso lo vamos a discutir en la sesión de preguntas. Ahora vamos a darle paso al doctor Zoilo Emilio García, quien es un joven psicólogo, pero con una amplia experiencia como como clínico. Incluso tiene un centro sobre cognición, emoción y salud. Y además tiene el coraje de asumir responsabilidades de gestión y en este momento es el director de investigaciones e innovación de la Pontificia Universidad Católica Madre y Maestra. Tiene un gran interés por diseminar la información sobre salud mental y ustedes pueden escucharlo todos los sábados a las 8 de la mañana. Tiene un programa en donde educa a la población sobre diferentes aspectos de mucho interés. Fortaleza importante como introducir la tecnología virtual como herramienta para manejar las enfermedades mentales. Y al igual que todos nosotros, él está ayudando, está aprendiendo. Es la primera vez que nosotros nos encontramos, la generación nuestra, de diferentes etapas, con un fenómeno de salud tan catastrófico como lo que ha pasado con la pandemia de COVID-19. Es muy probable que continuamente él reciba consulta sobre qué hacer, tanto de grupos como de instituciones, como de familias. Y por eso va a ser muy interesante escuchar al doctor Zoilo García, que nos va a conversar sobre salud mental en tiempo de crisis, caso de la pandemia con el COVID-19. Bienvenido, doctor Zoilo García. Estamos esperando por su presentación.
Muchísimas gracias, doctora. Siempre un placer compartir con usted. Bueno, el día de hoy, tal cual como usted acaba de decir, que comparto pantalla con ustedes. ¿Está viendo, doctora? ¿Sí? Perfecto. ¿Sí te escuchan?
Sí, se ve la pantalla. Se puede poner más grande, pero se ve bien y se escucha bien.
Excelente. Gracias también al doctor Modesto, un gran amigo y que ha hecho un trabajo excelente en la parte de moderación el día de hoy. Bueno, a partir del día de hoy hemos visto las diferentes huellas que esta pandemia ha provocado en la sociedad. Hay una huella económica muy fuerte, hay una huella definitivamente social, política, pero una de las huellas que va a ser más fuerte es la huella que va a dejar en lo referente a salud mental. Hay que entender que podemos cuidarnos del virus estando en casa. Si nos quedamos, salvamos vidas y, ¿verdad? Cuidamos a nuestros familiares. Pero ¿qué pasa? El miedo, quedándonos en casa, no puede irse. La tristeza, ¿verdad? De no compartir con nuestros grupos sociales porque hemos tenido que aislarnos, ir a un grupo social más básico, más primitivo, que son nuestra familia directa. El miedo ante una enfermedad nueva de la cual a inicios de marzo teníamos poca información, la irritabilidad. porque nos han, de alguna forma u otra, con el fin de cuidar a los demás, hemos tenido que aislarnos y hemos tenido que restringir nuestro espacio y pasar un tiempo importante con la familia. Que si bien uno dice, bueno, no es malo pasar tiempo con la familia, pero ese tiempo en exceso produce a veces irritabilidad en las personas. De forma general, esta pandemia produce diferentes emociones negativas. Hay que tener claro que las emociones no son malas, las emociones nos ayudan a adaptarnos en el día a día, nos ayudan a comunicarnos, nos motivan y nos ayudan a sobrevivir. Pero cuando estas emociones se presentan de forma frecuente o de forma excesiva, pueden convertirse en enfermedades emocionales, trastornos y desórdenes emocionales. Para tener una idea, las consecuencias para la
Doctor
salud
Zoilo,
mental,
disculpe. Lo que pasa es que aparece una franja gris en el lado, bueno, izquierdo mío. O sea, a la izquierda sería la derecha mía, ¿no? Creo que quizá también la derecha suya, pero en la pantalla en el lado izquierdo. Entonces, a ver si se podría quitar, exacto.
Ok, ¿aquí se ve mejor?
Sí, pero entonces ahora está arriba, la parte gris.
Ok. A ver.
Pero adelante.
Ok, seguimos entonces.
Okay.
Como les decía, las emociones nos ayudan a sobrevivir, nos ayudan a adaptarnos, pero cuando se producen de forma frecuente e intensa, tienden a convertirse en enfermedades o trastornos emocionales. Las consecuencias de esta enfermedad en la salud mental son varias y diversas, y no solamente las que tenemos ahora, sino las que vamos a tener en el futuro, en los próximos. Se prevé un posible aumento de suicidios y de diferentes trastornos, y los gobiernos no deben dejar de lado la atención psicológica. Entre las consecuencias negativas del confinamiento en el bienestar psicológico, por mencionar algunas, tenemos aspectos que engloban la disminución de la esperanza de vida y otros efectos psicológicos como son los síntomas de estrés postraumático, confusión y enojo. De hecho, especialistas de la área de salud mental en diferentes partes del mundo esperan que haya un aumento del estrés postraumático por las muertes que se están produciendo, de estrés crónico, trastorno obsesivo compulsivo, específicamente con la limpieza, trastornos de ansiedad generalizada, estrés postraumático, claustrofobia y pánico. Y dentro de lo que esto puede estar dirigido a la población general, pero el personal sanitario constituye una población de alto riesgo y que puede verse afectada por lo que es el síndrome de burnout o síndrome de estar quemado. La OMS, o sea, la Organización Mundial de la Salud, afirma que la prevalencia de los trastornos emocionales dentro de lo que abarca el presente y los próximos 3 años se puede duplicar. Y para tener una idea de cómo andan esos trastornos emocionales, vemos que en República Dominicana, solamente de los trastornos de ansiedad, la prevalencia es un 5.7% y de depresión un 4.7%. Aquí nos muestra también en este slide unas cifras de la cantidad de población que tenemos con estas patologías. Y si esto se duplica, ¿qué vamos a hacer? ¿Están nuestros centros de atención primaria preparados para enfrentar esta pandemia? ¿Están los centros de atención primaria preparados siquiera para prestar atención a la cantidad de personas con trastornos emocionales actualmente? Tomando en cuenta que los trastornos emocionales son la primera causa de discapacidad a nivel mundial, básicamente. Unos estresores claves que tenemos que tener en cuenta es la duración de la cuarentena, la cual esto ha superado todas las expectativas. Tenemos casi 3 meses. Lo que es el temor al virus, la frustración, el aburrimiento, los suministros adecuados. Gracias a Dios hemos contado con diferentes cadenas de suministro, los supermercados están trabajando bien, pero el no tener los suministros adecuados origina y es un estresor durante la cuarentena. También la información inadecuada, de la cual hay mucha gente, muchas páginas que a veces presentan información sin ninguna veracidad. Estos son los estresores durante la cuarentena, pero también tenemos estresores post cuarentena y aquí entran las finanzas, la huella económica va a ser muy grande y todo el mundo, esto estresa a las personas, así también como el estigma de las personas que han padecido o están padeciendo de este virus. En esta parte, desde las universidades, específicamente del grupo de investigación al cual pertenezco en la Pucamaima, que es el Laboratorio de Emociones, Salud y Ciberpsicología, el cual dirijo, estamos llevando a cabo algunas iniciativas y vamos a presentar cuáles son los proyectos que estamos realizando y cómo algunos resultados preliminares, básicamente, de cada uno. Aquí, uno de los primeros estudios es el tratamiento de los desórdenes emocionales en atención primaria. Estos proyectos, cada uno de ellos, ha podido llevarse a cabo, claro está, con el apoyo de los fondos CID, del MESID. Con este proyecto fue un proyecto ganador de fondos CID 2019. Lo que se pretende es llevar la psicología basada en evidencia y transdiagnóstica a lo que es los centros de atención primaria. Esto de abordaje transdiagnóstico consiste en un mismo tratamiento que puede ser aplicado a diferentes patologías, específicamente a las que son más prevalentes, los trastornos de ansiedad y los trastornos depresivos. También una característica de este ensayo es que es grupal y esto nos ayudaría a descongestionar muchas veces los que son los hospitales, la parte de salud mental, que muchas veces para tener una consulta tenemos que durar mucho tiempo en esta parte. También que son tratamientos basados en la evidencia. Es decir, hay una evidencia científica tras cada uno de los métodos de las terapias utilizadas en esta parte. Esto constituye una poderosa herramienta para afrontar esa escalada en lo que es la prevalencia de trastornos emocionales. Otras iniciativas que estamos llevando a cabo y que ya están en proceso de publicación, está lo que es las estrategias de regulación emocional en específicamente personal sanitario, en los doctores. Esta, es una investigación que hicimos con una gran muestra de doctores que estaban trabajando en los últimos 3 meses con el COVID. Y algunos de los resultados de este estudio que realizamos, y vuelvo y les repito, está en proceso de publicación por la revista Plus One, es el contacto con personas con COVID-19 predecía un mayor uso de estrategias de supresión de emociones en lo que son los doctores y el personal sanitario. Tienden a suprimir las emociones y esto no necesariamente constituye una disminución del estrés, sino que esta estrategia utilizada tiende a aumentar los niveles de estrés. Por eso, a partir de estos resultados, estamos creando un protocolo de atención específicamente para los doctores que están involucrados en el tratamiento a personas con COVID y que los niveles de estrés y burnout son muy altos. Otro de los estudios que hemos desarrollado, específicamente trabajando desde casa con el laboratorio, es el desarrollo de algunas aplicaciones, entre ellas la aplicación AIRE, Ayuda para la Regulación Emocional, el cual busca hacer frente a la ansiedad y al estrés. Esta es una aplicación que está disponible de forma gratuita para Android, está en Google Play, está basada en realidad virtual y permite a la persona desde su casa tener una forma de relajarse, disminuir los niveles de estrés y presentar información importante para regular las emociones. Esta aplicación está también en proceso de validación, la parte final. Ya estamos trabajando para presentar los resultados a la revista Behavior in Computer en la revista. Otra de las investigaciones que estamos realizando, esta con la Universidad Complutense de Madrid y la Universidad Siglo XXI, es midiendo el impacto psicológico de la epidemia del COVID-19. ¿Qué estrategias de regulación emocional puede ayudar a prevenir la aparición de trastornos emocionales? Esta investigación está realizada en población general. Pudimos obtener una muestra bien grande de la población dominicana, mayor de 1,000 personas, y algunos de los resultados preliminares de esta investigación que estamos trabajando es que de la población entrevistada, población casualmente que no presenta ningún trastorno emocional, pero sí estamos viendo que el 25% de la muestra ha presentado ataques de pánico, un 15% ha presentado trastornos de ansiedad generalizada, un 17% trastorno de pánico, y lo que hemos podido observar en esta parte de resultados preliminares es que las mujeres y los jóvenes tienden a ser los más afectados. Estas son algunas formas de cómo desde las universidades, desde los grupos de investigación, podemos crear valor y ayudar en este momento de la pandemia, resaltando la importancia, nuevamente específico, de tomar en cuenta la salud mental, que va a ser la huella donde va a causar más estragos. Entre las investigaciones futuras, bueno, estamos desarrollando otras aplicaciones para abordar el duelo patológico en el contexto de la pandemia, ya que hay muchas personas, bueno, que han muerto ya sea de la enfermedad o por otras causas y no han podido realizar ese proceso que tiene aspectos terapéuticos, el velorio, donde la persona va, recibe apoyo social. O sea, he tenido lamentablemente amigos y familiares que han pasado por esto y no pueden, ¿verdad?, aglomerarse las personas por el contagio de la enfermedad. Entonces, estas son algunas de las investigaciones. De forma general, y en cada escenario donde me ha tocado, siempre digo, bueno, no hay que tener un laboratorio para cuidar nuestra salud mental. Hay diferentes recomendaciones y diferentes actividades que podemos hacer cada uno de nosotros para cuidar nuestra salud mental. Estas son algunas recomendaciones específicas que han sido recomendadas por la Organización Mundial de la Salud. Entre ellas, y específicamente para comenzar a salir, debemos seguir cuidándonos, tanto física como mentalmente. Y hay cosas muy básicas que pueden ser muy conductuales, pero que tienen un gran impacto en la salud mental. Por ejemplo, establecer una dieta saludable, consumir menos alcohol y fumar menos. Siempre lo digo, siempre en los supermercados, cuando nos toca visitarlo, vemos siempre la área donde están los vinos, la bebida alcohólica, y hay muchas personas ahí fluyendo porque se ha bebido más en cuarentena. Entonces tenemos que tener cuidado con eso, y si hemos hecho algún desarreglo, tenemos que tratar de volver a cuidar nuestra salud física, hacer ejercicio, entre 30 a 150 minutos de actividad física para los adultos y por lo menos 1 hora al día para los niños. Con estas simples estrategias estamos cuidando nuestra salud mental. Otros puntos, no tener miedo, pero sí precaución. Tenemos que salir. Tenemos que volver poco a poco a los trabajos, siempre tomando en cuenta las recomendaciones de la OIT, la Organización Internacional del Trabajo. Pero que no tengamos miedo no significa que tenemos que dejar de tener precaución. No miedo, pero sí mucha precaución, cuidándonos, utilizando mascarillas, siempre manitas limpias, lavarnos las manos como medidas principales. Otra cosa, practicar la gratitud y mantener una actitud positiva. ¿Y a qué se refiere esto? Parece un poco holístico, pero esto a lo que se refiere es apoyar a otras personas en la comunidad y de una forma u otra crear valor en estos momentos. A veces en nuestro propio vecindario, nuestros propios barrios, hay personas mayores que no, tal vez no tienen la facilidad de hacer las compras o, qué sé yo, visitar un médico. Si podemos ayudar a esas personas, estamos creando valor y manteniendo una actitud positiva. Y aunque no lo crean, esto tiene un fuerte impacto en nuestra salud mental. Los más pequeños, bueno, a todos en mayor o menor medida nos ha tocado ser ahora profesores, niñeras, etcétera, etcétera, con los más pequeños. Debemos entender que la salud emocional de nuestros hijos es un reflejo de nuestra propia salud emocional. Si estamos constantemente asustados o irritados en casa, no podemos esperar que nuestros hijos, ya sean más pequeñitos o adolescentes, actúen de una forma diferente. Tenemos que hablar con ellos, dedicarles tiempo y explicarle de una forma adecuada a su edad lo que está pasando, básicamente. Por otro lado, y quizás una de las más importantes para finalizar, es el seleccionar la información. Nos sentimos de acuerdo a lo que pensamos, de acuerdo a lo que vivimos. Tenemos que ser cuidadosos a la hora de seleccionar la fuente de información. Asegurarse de que estamos utilizando fuentes fiables y oficiales, porque hay bastante información falsa en las redes y hay personas que no se desconectan de estas redes sociales. Siempre constantemente ansiosas, asustadas, viendo información sin ningún control. Entonces, no es solamente seleccionar la fuente de información adecuada, sino también dosificar la información. Si te vas a mantener informado, hazlo 1 o máximo 2 veces al día para evitar intoxicarte y no difundir informaciones falsas. En este punto, algunas recomendaciones del director regional para la OMS, para gobiernos e instituciones, y tenemos que tenerlas muy en cuenta. Número 1, distribuir el tiempo de información comprensible y fiable, dirigida a todo el mundo, que puedan entenderla los más jóvenes y las personas mayores. Ofrecer específicamente apoyo psicológico a los trabajadores que están en frente de la lucha contra el COVID-19, ya que es una población altamente vulnerable, así también como las familias afectadas. El cuidado y tratamiento de las personas con discapacidades mentales y psicosociales. Son personas vulnerables en estos momentos y los gobiernos tienen que darle un especial apoyo y cuidado. Y sobre todo la protección de los derechos humanos, especialmente los derechos de quienes normalmente son ignorados o violados, entre estos nuestros migrantes o las personas con discapacidad. Con esta parte cerramos lo que es mi participación y de forma general también recordarle algo. Nadie estaba preparado para experimentar todo esto. Si en marzo alguien hubiera dicho, mira, lo que viene es esto, quizás muchas personas hubieran dicho, no, yo no voy a poder soportarlo, pero lo hemos hecho bien. A veces somos muy fuertes para criticarnos, para castigarnos cuando hacemos algo mal, pero cuando hacemos las cosas bien también debemos premiarnos. Y creo que a pesar de lo que hemos vivido, hemos salido adelante. Muchas gracias.
Muchísimas gracias, doctor Solio García. Me encantó ese cierre final, porque tienes razón. Nosotros somos muy buenos criticando y culpándonos, pero creo que la República Dominicana, con todas las dificultades de sistemas y de estar todo preparado, hemos salido adelante. Y todavía tenemos muchas cosas por aprender. Bueno, vamos a empezar a la sesión de preguntas, algunas preguntas, porque por razones de tiempo no nos podemos extender, pero aquí tenemos para el doctor Carlos Rodríguez, Mariluz Motero Maldonado quiere saber qué tan infeccioso se puede considerar un portador asintomático. En estadio 1, dice ella.
Bueno, una persona que tenga una infección asintomática, porque hablar de portador realmente no sería la palabra, puede transmitir. Se sabe que inclusive mucho antes el que tiene síntomas, días antes de comenzar a tener síntomas, puede transmitir por igual. El asintomático, el que no tiene síntomas en la primera etapa, puede transmitir. Se sabe que con menos capacidad que el sintomático, cierto, pero igual transmite. Entonces, ojo con esto, que inicialmente, por eso es que muchas veces la gran mentira y la gran verdad están muy ligadas en estas cuestiones con enfermedades nuevas. Se hablaba de que el asintomático no transmitía, pero muchos estudios mostraron después, incluyendo la contaminación que hubo en un hogar en Washington, es que muchos de los empleados eran asintomáticos e iban a trabajar al home care sin ningún síntoma porque pensaban que no tenían nada y fueron los que le llevaron hasta los viejitos el SARS-CoV-2. Por tal motivo, sabemos perfectamente que unos días antes las personas ya están transmitiendo, los sintomáticos y los asintomáticos también, con menos escala, pero transmiten. Ojo con esto.
Otra pregunta, doctor. El señor Francisco Antonio y usted comentó sobre el uso de la dexametasona y cuándo usarse en pacientes con COVID-19, pero él quiere saber si es cierto que el uso de la dexametasona se puede usar para contrarrestar la enfermedad del COVID-19.
Bueno,
Francisco
es que en
Antonio.
realidad, como un antiinflamatorio potente, esa es la acción que tiene la dexametasona, igual que cualquier otro esteroide o antiinflamatorio. Entonces vamos a pensar que no son exactamente drogas antivirales que actúan sobre el virus. Sí pueden cambiar el curso de la infección, sí pueden ayudar a que no tenga el impacto grande sobre el sistema inmunitario y que puedan bloquear esa respuesta exacerbada inflamatoria, que es la que ocasiona mayor daño, principalmente porque ya en la etapa donde ya no hay más replicación viral, lo que hay es una respuesta exacerbada del propio sistema inmunológico que hace más daño al organismo. Entonces, el uso de estos antiinflamatorios como la dexametasona o cualquier otro esteroide, lo que va a ayudar a disminuir ese impacto de la inflamación sobre el organismo y por ende va a tratar de mejorar el paciente y recobrarlo mucho más rápidamente. Ya dije, el uso de la dexametasona es un trabajo del estudio Recovery que todavía no tiene una publicación en un medio indexado. Es simplemente un reporte preliminar del ensayo y por tal motivo en algunos países todavía no se ha cambiado de esteroide para utilizar en estos países. Ojo con esto.
La señora Andrea Josefina Tapia quiere que usted le reconfirme que de acuerdo a su exposición se puede inferir que no existe ningún medicamento realmente autorizado para el tratamiento del SARS-CoV-2.
Bueno, universalmente, si hablamos de medicamentos específicos ya licenciados para el SARS-CoV-2, en la enfermedad COVID-19, el Remdesivir como antiviral es una droga que la FDA en Estados Unidos ha aprobado para el uso en la enfermedad en el COVID-19. Igual el Remdesivir ha logrado la aprobación en otros países del continente asiático, por ejemplo, y en el del continente europeo. Como droga como tal, el Favipiravir, que ya era una droga conocida en Japón, que se utilizaba para influenza, los estudios rusos ahora lo han rescatado como tal y han mostrado, y para ellos está permitido como una droga que se puede utilizar para el tratamiento del SARS-CoV-2 o para la enfermedad COVID-19 en sentido general. Sin embargo, ellos por sí solos no parecen ser la solución al problema. Es decir, veremos más adelante cómo tal vez la solución como tratamiento pueda ser la asociación de varias drogas que actúan a diferentes niveles para poder inhibir la replicación viral y evitar que esto ocasione un daño y esa respuesta robusta y exacerbada del sistema inmunológico que trae como consecuencia esa liberación de sustancias, de citoquinas que dan daño en el organismo y que traen los problemas de coagulabilidad y toda aquella situación que ya conocemos y se ha descrito bastante, que hacen mucho daño y que son secundarias a esta respuesta inmunológica. Entonces, como tal, por eso es que decimos, todavía nadie ha dicho, esta droga resuelve, usted la toma y se acabó. No, hay que tener cuidado con esto.
Francisco Antonio tiene una inquietud interesante. Usted sabe que hoy precisamente estamos con el polvo del Sahara en todo el área del Caribe y aquí en Santiago amaneció bastante nublado, me imagino que por esto. Entonces, él quiere saber si usted puede inducir que el polvo del Sahara puede afectar o no la enfermedad del COVID-19.
Mira, lo que se puede en muchos casos enmascarar las personas que son hipersensibles, que ya tienen alguna hiperreactividad bronquial, personas que tienen asma u otro cuadro respiratorio de base, que la presencia del polvo del Sahara pueda traer la exacerbación de este tipo de problemas y confundirse en un momento dado los cuadros respiratorios de ambas entidades. O sea, pero desde el punto de vista que esto pueda traer una consecuencia, realmente nadie pudiera demostrar esto, sino simplemente que pueda agravar la situación de estas personas que ya tienen una condición respiratoria, y los que no lo tienen pueden confundirse en un momento dado creyendo que si tienen algún síntoma respiratorio sea por el polvo del Sahara y no sea exactamente porque están cruzando con la enfermedad. Entonces, ojo con esto, siempre va a haber la respuesta clínica y siempre la clínica y los síntomas van a ser soberanos y debe ser manejado por un médico que evalúe la situación en cada caso.
Doctor, ya con la cantidad de pacientes que usted ha manejado con COVID-19 en la República Dominicana, ya esto es una inquietud que yo voy a hacer por el grupo de médicos y clínicos, que le gustaría saber qué usted está utilizando para tratar los pacientes y cuándo usted considera que el paciente debe ser ingresado. ¿Y qué tipo de tratamiento usted está usando aquí en la República Dominicana que con su experiencia usted siente que le ha favorecido con el tratamiento de la enfermedad?
Mira, hablar de experiencia realmente y de empirismo yo creo que nunca es bueno, ¿no? Hemos estado llevando los lineamientos que tiene el protocolo nacional y lo que se prescribe, lo que se ha prescrito como tratamiento. Ya decíamos que los casos leves van a pasar en su casa si tienen condiciones de aislamiento y con cama, cariño, líquidos y sintomáticos es suficiente. Sin embargo, aquel grupo pequeño, porque llega a ser un 15%, que ya tiene cuadro de dificultad respiratoria o que ya tiene cambios a nivel de laboratorios que nos hablen de que el paciente está desarrollando un proceso sistémico o tiene hallazgos tomográficos o en imágenes que sugieran que ya vienen situaciones importantes, porque muchas veces el paciente puede estar saturando muy bien y cuando le haces el estudio de imágenes te das cuenta que el pulmón ya tiene infiltrados en vidrio esmerilado y que es un paciente que amerita se tome una conducta y se hospitalice para poder iniciar una serie de terapéuticas, entre ellas la anticoagulación, los anticoagulantes, el uso de esteroides, y hasta estos momentos se ha estado utilizando, porque en Dominicana no tenemos ni Remdesivir ni tenemos Favipiravir, y se había estado utilizando como tal el uso de la hidroxicloroquina, inicialmente combinada con la citromicina, y luego se dejó de utilizar tanto por los hallazgos electrocardiográficos y las complicaciones que podía traer en personas mayores, a utilizar inicialmente la hidroxicloroquina y en algunos de edad pediátrica, pues sí, la acitromicina también, pero básicamente es lo que está utilizando en menos proporción los antirretrovirales, porque para pacientes graves, por ejemplo, la disponibilidad de antirretroviral por el lopinavir, ritonavir líquido para poder administrar realmente es escasa, pero de cualquier manera, básicamente esto es lo que se había estado utilizando. Ivermectina jamás hemos utilizado porque no tenemos la evidencia. Ojalá pudieran los estudios decir que es algo bueno y que la dosis pudiera determinarse cuál sea la que sea verdaderamente eficaz para tratar, pero nunca hemos utilizado ivermectina ni como profiláctico ni como tratamiento tampoco. Obviamente ya el paciente que pasa cuidados intensivos pues puede ameritar ya el uso de tocilizumab como un inhibidor de interleuquina ante la presencia de la cascada de citoquinas que pueden hacer daño a nivel pulmonar, pero básicamente es el tratamiento que hemos tenido en todo este tiempo en República Dominicana. No tenemos ningún estudio aleatorizado que nos esté avalando esta situación. Simplemente estoy contando lo que hemos hecho, pero esto no se puede calificar como una evidencia. Esto es algo más observacional, más desde el punto de vista anecdótico lo que pudiéramos transmitir. Veamos ahora que, por ejemplo, en Dominicana va a comenzar el estudio Solidaridad de la OMS y ahí puede tenerse alguna experiencia. Pero en Dominicana hay que tener mucho cuidado porque mismo los pacientes hospitalizados, las conductas no son llevadas a cabo 100%. Y eso es evidente y todo el que me está viendo o oyendo sabe que es así. El paciente lleva en las carteras medicamentos y toma uno y toma otro y alguien por teléfono le dice que tome lo otro que llevó y alguien le lleva cosas o le manda cosas y todo eso hemos visto en esta pandemia, que la gente hace muchas veces lo que le parece y oye mucha información, porque si usted se fija en las redes existen 30,000 recetas de combinaciones de medicamentos y productos que la gente da por hecho son buenos para tratar el SARS-CoV-2, pero realmente no. Esto es lo que puedo decirle como mi experiencia en el tratamiento.
Excelente, doctor Carlos Rodríguez. Ese problema de la sobremedicación, esta pandemia como que ha desnudado la cultura dominicana y la ha multiplicado exponencialmente. O sea, las cosas que el dominicano hace de manera regular se nota más y también las cosas buenas que tiene se nota más. Y uno de los problemas más serios, y que incluso en la práctica de los médicos internistas es una causa frecuente de complicación, es la sobremedicación. Y me consta que poder transmitir información correcta para no causar daño es importante. Y escuchar a la persona que tiene el experticio, porque en este momento yo noto que periodistas, políticos, la vecina, y los dominicanos tienden a creerle incluso a veces más por su deseo de, aquí todos quieren ser médicos, eso es una situación cultural. Sí, y todos creen que saben. Y no le he comentado a los panelistas la cantidad de comentarios de excelencia que tenemos. Entonces, las preguntas, lo que yo quiero hacerle al doctor Zoilo Emilio García es justamente si es cómo abordar el problema cultural de esta aceptación de información inadecuada en su quehacer. Yo siento, o sea, los médicos y el personal de salud con frecuencia es más cuidadoso y temeroso en el uso de medicación. Sin embargo, el dominicano de a pie, el dominicano común, tiende a no solamente a usar medicina alternativa y creerla como que tiene el poder y ayuda a veces un poquito de fe y un poquito de té de limón, pero a veces es muy osado y las farmacias no tienen control. ¿Cómo podemos psicológicamente ayudar a que el dominicano adquiera un poquito más de validez científica? Porque la cultura como que no ayuda. Incluso yo tengo médicos, amigos, que ven la ciencia como si fuera solamente el aspecto negativo. Y es una situación que hemos manejado durante 30 años en mi tiempo en la práctica. Es más fácil creer como hay una cultura como mágica en un mundo que no quiere creer la verdad, y eso ha pasado por muchos siglos, pero psicológicamente es posible abordar esa resistencia cultural a la información científica.
Bueno, de forma general hay muchas variables que pueden intervenir, ¿verdad?, en esa respuesta, pero yo creo que algo que puede ser sencillo es simplemente la información que está basada en evidencia científica a través de los diferentes medios, hacerla llegar a la población. Eso yo creo que es la recomendación inicial. Hay muchas, como las que dije, informaciones y recomendaciones de la OMS en la parte de salud mental. En muchos casos, ni los profesionales de la salud mental la la saben y son informaciones que están publicadas. Entonces yo creo que es muy importante el hecho de dar a conocer a la población lo que está pasando y en un lenguaje que ellos puedan entender. Y tenemos que tener claro con estos aspectos, doctora, que me dice de la parte mágico-religiosa, es que tenemos terraplanistas todavía. Siempre va a surgir algo de esto. Yo creo que a través de los diferentes medios, llevar la información fidedigna a la población de una forma que pueda entender. Porque a veces, ¿verdad? Si venimos con términos muy científicos o algo así, es más fácil para la persona eso. Básicamente.
Muy bien.
Zunilda.
Sí, te escucho.
Pienso que, y Zoilo, que hemos tenido una diferencia con esta pandemia y es que quizás la primera pandemia en tiempo real, como yo llamo, porque están las redes sociales ahí. Entonces las redes sociales son muy buenas porque transmiten mucho más rápido que los medios escritos y televisados la información, pero transmiten buena y transmiten mala. Y la gente muchas veces, como dice Zunilda, la gente de a pie, la gente del pueblo, no distingue ni siquiera de dónde proviene, ni confirma si lo que le están diciendo es correcto y la hace suya como si fuera una evidencia total. Y muchas veces vemos esto no solamente en el pueblo llano, en el vulgo, vemos eso también en la clase médica, que quizás se toma muy en cuenta lo que la clase médica dice, pero hay mucha clase médica desinformada, trabajando sin información científica y sin evidencia, dando conductas como si fueran buenas y válidas. Entonces la gente está confundida porque lee por un lado una cosa, oye a alguien diciendo otra, y yo creo que ahí es que está bastante confuso todo.
E incluso yo creo que esta pandemia ha puesto en evidencia la urgente necesidad de que nuestros centros clínicos se conviertan en laboratorios de investigación automáticos.
Claro.
Tengamos datos de validez. Por razones de tiempo, yo con ustedes me quedaría conversando horas, pero muchas gracias. Muchas gracias, Modesto, y el Ministerio de Ciencia y Tecnología, porque esto hacía falta. Yo creo que hay que repetir, por lo menos la parte de salud, cada mes debemos hacer un refrescamiento de actualización, porque así ya vamos a tener más datos. Gracias, Modesto, y un honor haber participado con ustedes.
Gracias.
Bueno, quiero primero externar el agradecimiento y felicitar a los expositores y moderadores y relatores del MESIT y del viceministro de Ciencia y Tecnología, don Plácido Gómez Ramírez. De mi parte, ya debo de concluir y también quiero dar las gracias nueva vez a nuestros expositores, a la moderadora, en este caso la doctora Zunilda Núñez, por compartir sus conocimientos científicos con la comunidad dominicana a través de este simposio organizado por el Ministerio de Educación Superior y con la colaboración de varias instituciones académicas y de investigación nacionales e internacionales. También gracias a todos ustedes por estar con nosotros esta noche y por generar tantas preguntas interesantes en español y en inglés. Quiero agradecer al MESIT y al Viceministerio de Ciencia y Tecnología, dirigido por el doctor Plácido Gómez Ramírez y todo el equipo por otorgarme el honor de coordinar la sección de salud y biomedicina de este simposio internacional, el cual se titula Investigación y Soluciones Científicas en Tiempo de Crisis, COVID-19 y más allá. Seguridad alimentaria, salud, educación y medio ambiente y economía, y que fue inaugurado en el día de ayer. Antes de despedirme, quisiera recordarle que mañana continuará el desarrollo del simposio con la temática de medio ambiente. La misma será dirigida por el distinguido profesor Sixto Inchaustegui, miembro de la Academia de Ciencias de la República Dominicana y asesor del Ministerio de Educación Superior, Ciencia y Tecnología, MESIT. Les esperamos mañana, entrando por los mismos enlaces, el mismo link, la misma ID y contraseña con la cual usted pudo conectarse en el día de hoy. Nueva vez, gracias y feliz noche a todos.
Buenas noches.
Estuvieron magistrales todas. Gracias, gracias Carlos.
Gracias a ustedes por la invitación.
Gracias a ustedes. Bye bye.